So, very good evening everyone. Good evening everyone. Let me know in the chat box if you can hear me well and see me well. So, very good evening everyone. Hope all of you are doing good. So, today we are having a special session for the FMGE students. So, very good evening everyone. Hope you are doing good. All of you are doing good. Let me know in the chat box. Let me know in the chat box if you can hear me and see me well. Good evening. Good evening, Yadav Khan. Good evening. Everything is fine. Good evening, Paras. Okay, great. So, we'll be having this session today, as we are having session of different subjects. So, today we'll be taking up psychiatry. Great. So, thank you. Thank you, Paras. Good evening, Shalini. Good evening. So, what we're going to do is, we are going to discuss the flashback. We are going to discuss PYQs of psychiatry. So, we are going to discuss important PYQs. Good evening, Dr. Tafsif. So, we are going to discuss important previous year questions today. So, not just 5 years, maybe 7 to 8 years questions, important questions we are going to discuss, and we are also going to discuss some important previous year topics which will be useful for our exam. So, as we all know, the date has been announced. It is on 30th of July. So, roughly 65 days we have. So, we are going to cover some important high yielding topics and high yielding points I will be covering, and very important today we will be discussing FQs. FQs are the future questions expected, questions which you can expect in the exams. They may appear new questions which we will be discussing, covering those questions also in the session today. So, good evening, Subhashish. So, let us start with the first question. Let us, I will be covering these questions according to the topics. So, the first topic which we will be covering today is the basics. Again, let me tell you, basics, the topic of basics of psychiatry is very important. Each time you get 1 or 2 questions from this topic. So, what is the answer? What is the answer of this question? Delusion is a disorder of which of the following? So, let us see. So, delusion is a disorder of, is it thought, affect, perception or memory? Very good. Yes. The right answer is yes. It is a disorder of thought. So, please have a look at this. Some simple questions also come. So, what is delusion? So, as we all know that thought under the MSc is divided into 4 domains. One is flow of thought, content of thought, form of thought and possession of thought. And delusion comes under the content of thought. So, this also may be told. Good evening, Ashwaki. Yes, very good. So, dopamine agonist, Paras, Dr. Akhtar. Yes, it is A. So, what is delusion? Delusion is a false belief. It's a false, fixed, firm belief which is held with extraordinary conviction. Delusion is a belief which the patient is holding, although it is false, but he is convinced. For example, a patient says that my neighbor wants to kill me. Everybody is trying to tell him that it is not true, but this belief that the neighbor wants to kill me, he is holding it firmly and he is not thinking otherwise. So, what is this? This is delusion. So, there are various delusions. Can anybody tell me which is the most common delusion in psychiatric disorders we see? Which is the most common delusion? The most common delusion is delusion of persecution. Delusion of persecution. So, the example which I just gave you. So, a person believes that someone is planning to harm me or kill me. This is delusion of persecution. Very good, Dr. RJ. Very good. So, then there are other delusions such as delusion of reference, wherein the person feels that things are occurring in reference to him, like people are talking about him or someone is spying on him. So, these are some of the delusions. So, please remember, it is again very important. You should know what all abnormalities come under flow, content, form, possession. Can anybody tell me quickly, obsession comes under which of the domains of thought? Obsession, very good. Yes, there is grandiosity, wherein the person have false big claims that maybe I have supernatural powers or I know famous people. Very good. That is also there. So, can anybody tell me where does obsession come? So, it's a question for all of you. Obsession, very good. Yes, Yadav, yes, Shwani, very good. All of you are correct. Obsession is a disorder of possession of thought. We will talk about obsession in OCD. Yes, it is under possession. Now let's come to the next question. Again, very interesting question. Please have a look in the basics in the FMG exam. Many a times they are asking questions like a psychiatrist is talking to a patient. Psychiatrist, patient is saying certain things and then they ask you what is this phenomena. So the next question, again very interesting question. A patient says home is sweet, sweet in diabetes, diabetes urine has smell, smell is hell. What is this symptom? Can anybody tell me what is this symptom? The options are tangentiality, flight of ideas, neologism, loosening of association. What is the right answer here? Please see. Here if you see, is there any connection between these thoughts? Although these thoughts may appear illogical, but is there any connection? Can you see any connection in these thoughts? Home is sweet, sweet in diabetes, diabetes urine has smell, smell is hell. Again, this is your FMG 2019 question. This is very importantly, please remember, this is flight of ideas. This is flight of ideas, which is a abnormality of flow or stream of thought. We'll talk about this. While all the others, that is tangentiality, neologism and loosening of association. Can anybody tell me under which domain of thought? Can anybody tell me under which domain of thought these come? Tangentiality, neologism and loosening of association. They come under form of thought. So we'll talk about this as well. So this is flight of ideas. Let us understand. So again, flight of ideas is an abnormality of flow. So flight of ideas, what happens? Flight of idea, what happens? There is increase in the speed of thoughts. So in the mind of the patient, the thoughts are occurring very, very fast. One thought, second, third, fourth, fifth. So the patient is speaking very, very fast. My name is Dr. Goel. I'm a psychiatrist in Delhi. I like playing cricket. So patient is speaking very, very fast. But although these thoughts may appear illogical, but they still have some connection. These are connected. So each of these thoughts may be connected. There is some connection. This connection can be either by chance, So another example, let me give you another example. I always give this example, if the patient says, my name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही तो ढूंढे. Something like this. So one thought is connected by other by chance factor, or it may be connected by what is known as clang association, which is rhyming words. Okay, so patient may say like this, Ram can sing, birds have wing, I am the king, the phone goes tring tring, the weather is spring, bring, 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 something like this. So if you see, these thoughts are connected by rhyming. So this is flight of ideas. Please understand, in the written question, you may not be able to analyze the speed until unless they tell you that the speed is increased. But see how these thoughts are connected. In flight of ideas, these thoughts are connected. Very, very important. This is your FMG question. You should know these concepts. So is it clear to everyone? Flight of ideas. Now can anybody tell me one important condition in which you find flight of ideas? It is seen in. Can anybody tell me ये कहाँ पे मिलेगा? Where it is seen? Where it is seen? Can anybody tell me? It is seen in which condition? It is seen in mania. It is seen in mania. So this is again very, very important, especially thought. Thought is a very important topic in psychiatry. Many questions have been asked from this topic. Now let's come to the next question. Again, if you see, similar questions have been asked. A psychiatrist asks a patient, yes, very good Paras, dopamine agonist, very good Shasti, very good. Yes, it is mania. Disha, yes, it was mania. Now let's come to the next question now. A psychiatrist asks a patient, how is your mood? And the patient replies, it is going up and down. What is this likely phenomena? So what is this phenomena? What is the answer to this question? Anybody? See, this is the question of your exam. Ria, very good. Arham, okay. Devtaru, B, yes. This is again very, very important topic. Again, under thought only we will discuss. This is tangentiality. The right answer is tangentiality. Let's try to understand. If you see, this is some basic questions they are asking. You should know these concepts. So now let us come to form. Let's talk about form. So form means organization, you know, so our thoughts are organized. So if there is disruption of form, we say there is disorganization of thought. So if the form is abnormal, we call it as formal thought disorder. Formal thought disorder. Okay, so they may just ask you which of the following is a formal thought disorder. So you should know what some of these important formal thought disorders. So let us try to understand from the name itself. First is loosening of association. So the name is telling you loosening of association means that the association or the logical connection between the thoughts have been broken. So there is a break in the normal connection. So what will happen? The patient will speak things, you will be able to understand words, but you will not be able to understand the meaning. For example, patient may say, I will eat, I will come back, I will book a cab, I will order coffee, I will not go. So patient is saying certain things, you are able to understand the word, but you are not able to understand the meaning. This is loosening of association. If you see the previous question, in this question sometimes we may confuse this question with loosening of association. So it is not loosening of association because we know the connection is seen in flight of ideas. Okay, so let's come back. So one is loosening of association. Second is derailment. Let us try to learn from the name. What is the meaning of derailment? Derailment means that the train or the rail is moving on track and suddenly it gets derailed. So what is happening? The person's thought jump off the track to go to a new topic. So patient is speaking to you on a topic. So patient is talking to you, let us say the patient is talking to you that, you know, the weather is, climate is becoming hot, humid, I think I should, you know, take out my, you know, summer clothes. And, you know, the patient suddenly changes the topic. I'm watching, you know, IPL matches and, you know, this team is doing well. So the patient has changed the track. This is derailment, sometimes also known as night's move thinking. Next is tangentiality. Again remember it from the name. What is tangentiality? Tangentiality. So let us try to remember it with the name. What is a tangent to a circle? A tangent to a circle is a line which touches the circle at one point and goes away. Does a tangent ever comes back to the circle? No. So what is tangentiality? The person touches the topic. So you ask some question to the patient, he touches the topic and he goes away, but he never returns to the goal. He never returns to the goal. Okay. Yes, Arham, the goal is not reached. We'll discuss about that in the question. Okay. So this is tangentiality. Is it clear? In derailment, the person should be on track and then there should be evidence that he has changed the track. He is going to a new topic. While in tangentiality, the person touches the topic and he goes away. He does not come back to the topic. Lastly, what is neologism? What is neologism? In neologism, as the name says, neo means new. Logism, logos means word. So person, you know, out of nowhere, he uses a word which is not there in the language known to the patient. So suddenly out of nowhere, you're talking to a patient normally and suddenly the patient may say that I bought a new Pratt knit wit. So, you know, he knows only English language and suddenly he says that doctor, I've got a new Pratt knit wit. So again, you know, you will say what is this? So he has derived a new word whose derivation we cannot understand. This is neologism. All these formal thought disorders, can anybody tell me in which condition? Very good, Paras. Yes, coining of new words. Yes, Anju. Can anybody tell me, beta, the formal thought disorders in which condition you will find? You will find it in schizophrenia. In schizophrenia, we'll talk about this. So basically, formal thought disorder means disorganization. So we'll talk about schizophrenia and one of the symptom criteria is disorganization of speech or thought. Now let's go to this question. Now this is again, it may be an incomplete question, but let's try to answer this question. So you ask a patient, how is your mood? It is going up and down. This is what he's saying. Now it is not clang association, of course. You know, so clang association, we know that, you know, to be clang association, patient has to speak certain number, you know, a lot of things, and then we see some connection. Neologism, again, there is no word which is new, right? Now, between derailment and tangentiality, please understand, to make it derailment, first we should know that he is on track and we should also know that he has changed the track, he jumped off the track. That is not evident. Now, he is saying it is up and down, he is not saying it is happy and sad. This is what we are assuming. So, maybe he has just touched that topic. So he's touched the topic. Again, it seems to be an incomplete question, but out of the 4, the best answer is tangentiality. Tangentiality, very good. Debatru, Yadav, Kant, Anju, yes, that is seen in formal thought disorders. These are seen in schizophrenia. Is it clear to everyone? These are very conceptual questions. You should know the important concept behind these terms. Is it clear to everyone? As you can see, they are asking simple, but they are asking conceptual questions. Okay, this question was asked in NEET PG exam. For which one of the following is a formal thought disorder, and in that the answer was derailment. So such simple direct questions may also be asked from these topics, right? Now let us come to the next question. Again, this is your 2019 question. A person finds decrease in interest in activities which he would enjoy previously. What is this? Then yes, then it would have been happy answer, then you would have been direct, then that wouldn't become a question. You know, had it been seen directly, he has said happy answer, then you know he's answered your question. Then it was, you know, we could not have identified. Very good. What is this? This is, yes, this is anhedonia. Very good. So all of you are marking it correct. Yes. So please see such simple questions are, you know, being asked from this topic, very important. So there is a decrease interest in previously pleasurable activity. So patient says, sir, earlier I used to enjoy going to movies, you know, going to a kitty party, you know, doing, you know, listening to my favorite music, but now I don't find interest in these things. Now can anybody tell me in which conditions you may find anhedonia? Where will you find anhedonia? First, again, simple, we can find it in depression. We can find it in depressive disorders. Any other condition can you find anhedonia in? Anybody? Yes, it is correct. Very good, Aram. Yes, it is. It can also be seen in schizophrenia. Very good. Even in schizophrenia, in fact, we'll talk about this. There are negative symptoms of schizophrenia. We'll talk about positive, negative symptoms. It is one of the negative symptoms of schizophrenia. Very good. Okay. Is it clear to everyone? What is alexithymia? What is alexithymia? Again, this is a option which is given. Alexithymia is inability to be aware. Patient is not aware or is not able to describe his emotions. He is not aware or he is not able to describe his emotion. That is alexithymia. Tangentiality we have discussed. Asociality, again, asociality is also a negative symptom. That means decrease in the socialization, decrease in drive to socialize. Very good. We'll talk about the negative symptoms. Very good. 5 important symptoms. Yes. So please have a look. Such simple questions come. Now this is your, you know, question of 2023. So again, this is a 2023, the latest, you know, last exam question on MSc. What is MSc? MSc is mental status examination. So examination, psychiatric examination which we do in a patient, it is known as mental status examination. So patient is asked to subtract 7 from 100. What are you assessing? What is the answer? So again, these are again recently, this is a recent last exam question. The orientation, attention, confusion or concentration. The right answer is yes, it is concentration. Let's try to understand. So what are they assessing? They are assessing higher mental function. So in MSc, we assess higher mental function or cognitive functions. Some of these important cognitive functions. One is orientation. We ask the patient about time, place and person. So orientation is with respect to time, place and person. So right now all of us are aware of the time, the day, the date, the month, the year. So we are oriented to time. We know where are we right now. So all of you know where are you right now. So this is you are oriented to place, and also you know people around you who are there at present. You also are aware, oriented of the person. So this is orientation. This is orientation, right? Next is attention. What is attention, beta? What is attention? Attention, you know, in school days teacher would say pay attention. So what is the teacher trying to say? That pay attention to my voice. So pay attention to a specific stimulus. So this is attention. How do we check attention in a patient? The test which we do to check attention is digit repetition test or digit span test. So what is this? So as the name suggests, we give some digits or numbers to the patient and the patient has to repeat those numbers. It can be either in the forward direction. So suppose I give the patient this digit 2, 7. So patient also has to repeat it in the same direction. He will say 2, 7. Then I will increase the number of digits. So this is digit forward. Digit backward is when I give digits to the patient and he has to repeat it in the backward direction. Okay, so these are the tests for attention. If you have to choose one between digit forward and backward, then for attention this is a better answer. Okay, so this is about attention. What is concentration? You know, many a times, you know, we all of us say, you know, that, you know, sir, I'm not able to concentrate. After half an hour of study, I lose my concentration. So what is concentration? Concentration is sustained attention, attention for a long time. So how do we assess concentration? The test which we do is serial 7 subtraction test or 100 minus 7 test. Very, very important. So we tell the patient to subtract 7 out of 100. Whatever the answer comes, keep on subtracting, keep on subtracting. Okay, so if you can see, you know, to do this task, the person has to sustain his attention. So what are we checking? We are checking concentration. Is it clear to everyone, beta? This is not orientation. For orientation, we'll ask about time, place and person. Attention is not there. Confusion, basically, if the person is disoriented, then person may be confused, may appear confused. So this is concentration. Is it clear to everyone? Again, these are important questions. Let's come to the next, again a very, so we've talked about some questions which have asked from the basics. So I'm going to, in this, you know, session, what I'm going to also try to tell you is, you have, you know, 65 days. So while we are preparing, we'll focus on some of these important previously asked topics. So basics, you have seen many questions have been asked. The second topic which we are going to discuss, it's a small topic. It's a small topic, that is organic mental disorders. But if you see, especially in your FMGE exam, lots and lots of questions have come in, you know, somewhere or the other in certain exams. Okay, so this is a very important, short but important topic for you. And one important thing which I would want to tell you is, many a times, especially in psychiatry questions, what the examiner do is they play with words. They will ask you a simple question, but they will change the language. So you have to see what they are trying to ask. Let us see. This is a simple question. We talk about this all the time. Which of the following is not suggestive? Which of the following is not suggestive of a medical cause of mental illness? First of all, let's try to understand what they are asking. When I say medical cause of mental illness, that means there is a apparently visible cause, a medical cause of mental illness. So what is this known as, beta? This is what is known as organic mental disorder. Now let me reframe the question for you. The question is now, which of the following is not suggestive of organic mental disorder? Now can you answer this question? They're trying to ask you which of the following. This not is also important, beta. They're asking you which is not suggestive of organic mental disorder. Now can you answer this question? Let's try to answer this question again. So the options are elderly age. Organic mental disorders, we know, like delirium, dementia, may be seen in elderly age. Acute onset, we know delirium, one of the organic mental disorder, has a acute onset. Loss of consciousness, delirium, we know that there is impairment of consciousness. Can anybody tell me in the organic mental disorder, which hallucinations we often discuss is more common? Which hallucination is more common in organic mental disorder? What are hallucinations, beta? Hallucinations are disorder of perception. It's a false perception without any object. For example, patient is saying, I am able to hear some voices. Nobody is able to hear any voice, but the patient is able to hear it clearly. So this is a false perception without any real object. Similarly, patient may say that I can see something. There is a person standing, you know, just next to me. Nobody can see, but he is able to see. This is visual hallucination. So we always discuss, so which hallucinations are more common in organic? So what they've done is they have just twisted or they've played with the word. So we know in organic mental disorder, the hallucinations which we often see is visual hallucinations. Visual hallucination. So this is the answer. It is D. D is not suggestive. In fact, In psychiatric disorder overall we say auditory hallucinations are the most common, but organic mental disorders we say visual hallucination. Is it clear to everyone? This is very, very important. Please see these questions, simple questions but twisted language. Many times they have done this. So we know psychiatric disorders are divided, again it's a previous way of classifying these disorders as organic disorders and functional. Organic means there is a visible apparent cause. For example, someone has developed a head injury after which he develops some psychiatric symptoms, or someone has developed encephalitis. You can take out the counts, blood counts, CSF counts, and you can see it. Functional is that a disorder has no apparent or visible cause. So it is divided into neurosis and psychosis. Now we know that nothing is functional. Even depression, schizophrenia, they also have some cause. Neurotransmitters are involved, genetic factors are there. This is the old way of classifying. But again, understanding this classification is useful. Organic mental disorders are now known as, in both DSM-5 and ICD-11, very good, yes, ICD-11, they are now known as neurocognitive disorder. Please better look at the name, neurocognitive disorder. That means there is impairment of cognition. So there are cognitive functions are impaired with a neurological cause, neurocognitive disorder. Let me give you again briefly idea about these disorders. Again I am saying this is a small topic, but many times they have asked question. So let us see neurocognitive disorders. Three important neurocognitive disorders. One is delirium, the other is dementia, and the third is organic amnestic disorders. Can anybody tell me which is the most common? Which is the most common? Yes, Anju, there is no stimuli present in hallucination. Yes. Can anybody tell me which is the most common organic mental disorder? Please remember, the most common is delirium. It is usually acute in onset. Suddenly the symptoms will develop. Now in delirium, first is there is impairment of consciousness. Very good, yes. All of you are correct. Yes, it is delirium is the most common. Consciousness is impaired. So consciousness of the person is impaired. This is important. Consciousness is impaired. How do you know in the question? So what words or what symptoms will be given, that will tell you. So please try to remember. So they may tell you that there is altered sensorium. Okay, sensorium is altered, or they may tell you that there is clouding of consciousness. There is clouding in the clear sky. Now there are clouds. So clouding of consciousness. There is confusion. Patient is appearing confused, or they may tell you that there is disorientation. Patient is disoriented to time, place and person. This is suggesting that there is impairment of consciousness. And along with impairment of consciousness, even the cognitive symptoms are also impaired. Okay. So what are the cognitive symptoms? We will talk about this. Because it's a neurocognitive disorder, we know cognition is also impaired. Very importantly is there is impairment of consciousness. Next is dementia. In dementia, the consciousness is intact. Only thing which is impaired is cognition. Only cognition is impaired. So what kind of symptoms you may get in dementia? So you may get symptoms such as amnesia. Amnesia means loss of memory. There may be aphasia, loss or impairment of language. There may be apraxia. Very good, yes. Apraxia. Praxia means movement, loss of fine movement, such as symptoms like patient is not able to comb his hair, not able to unbutton his clothes, and not able to untie his shoelaces. Such problems may be there. And there may be agnosia. Patient is not able to identify objects. Show him this pen and he will not be able to identify. He is not able to identify faces. So such cognitive impairments are seen in dementia with clear consciousness. Okay. While in delirium, both consciousness and cognition are impaired. Delirium is usually acute in onset. Is it clear? Yes. Now then next is amnestic disorder. But as the name is suggesting, delirium में what all were impaired? Both cognition and consciousness. Dementia में only cognition. In amnestic disorder, out of the cognition only memory is impaired. So can you see this flow or hierarchy where what we have discussed? So only memory is impaired. That too only recent and remote memory is impaired. One of the very important cause which leads to amnestic disorder, we'll discuss about this, is Korsakoff syndrome. What is Korsakoff? Where will we study Korsakoff syndrome? So Korsakoff syndrome, where will we study Korsakoff? We will study, yes, patient forget daily routine, yes, cognitive symptoms, very good. So Korsakoff syndrome we will talk about in alcohol. It is occurring because of vitamin B1 deficiency. So there we will remember that what all symptoms may be there, amnesia may be there. Is it clear to everyone? Now let's talk about this again. I am telling you questions on this topic has been being asked again and again. So it's a 2018 question. I'll also discuss some more older questions also, so that we get an idea of what type of questions. So this is an important topic. Most common organic mental disorder we have just discussed, very good. It is delirium, very good. So I'm happy, yes, you are answering correct, yes, it is delirium. We have discussed this, right. Again, please see in 2021 also question has come from this topic. Deficiency of which of the following is a reason for cognitive impairment in old age? What are they trying to ask you? So they're trying to ask you deficiency of which of the following is causing, indirectly they're trying to ask you dementia. Dementia is cognitive impairment and usually it is seen in old age, isn't it? So they're trying to ask you, so please see the words. They often play with the words like this. So try to see what they are actually asking. So now can anybody tell me deficiency of which of the following? Deficiency of which of the following? Very good. One of the most important vitamin deficiencies which you should remember is vitamin B12. Vitamin B12. Others can also cause some of them. One of the very important deficiencies which you should remember is vitamin B12. Let's try to see. So in types of dementia, we divide dementia into reversible and irreversible. Most of them are progressive, but around 10 to 15% of the dementias, they have a reversible cause. And this question again has been recently asked in the last INI-CET exam. So they had asked the question which they have asked you in your exam, they had asked now currently in the INI-CET exam. Let's try to see some of these causes. So neurosurgical causes such as normal pressure hydrocephalus, or such as subdural hematoma or hemorrhage, or suppose there is a tumor in the brain, there is some abscess, you treat it and the dementia symptoms will be reversed. So neurosurgical conditions, yes, we'll talk about Korsakoff, very good. Next is infections. So infections such as encephalitis, neurosyphilis, you treat the infections, the dementia will be reversed. Very importantly again, metabolic causes. So metabolic causes, and one of the important causes which I want you to remember is deficiency of vitamin B12. Other deficiencies can also be there, but yes, vitamin B12. Even endocrinal disorders, and again very important endocrinal disorder which I want you to remember is hypothyroidism. Even hyperthyroidism, hypo and hyperparathyroidism can cause reversible dementia. So again these are important points, and even some other factors such as alcohol. Chronic use of alcohol can also cause dementia. It causes certain other neurocognitive disorders which we will discuss, such as Wernicke's and Korsakoff. Usually discuss that. But alcohol can also cause dementia, which is usually reversible. So if a patient stops taking alcohol, the dementia may get reversed in an year. Even the changes in the brain may also be reversed. So these are some of the important causes. Please remember this. I always say, hashtag, anything which is trending, I put a hashtag. This is a very important topic which you should be thorough with. Is it clear to everyone? Now, let's talk about this another question again in 2021 it was asked. Elderly male patient is diagnosed with Alzheimer's disease. Which of the following neurotransmitter is reduced in this condition? So what is the answer? Let me add one more option. Let us say they also mention glutamate. Let us say they also say glutamate. So I have just added one more option. So tell me, what is the answer? Ria, okay, B, Debtaru, serotonin, Nature with Medicos, Dr. Gamer. So some of you have very interesting names. Anju, very good. Yes, all of you are correct. It is acetylcholine. Very, very important. Acetylcholine is reduced. Glutamate also, is, there is also changes in glutamate. In fact, glutamate is increased. So they have asked which of the following neurotransmitter is reduced. Very good. So the answer is acetylcholine. So Alzheimer's disease in fact is the overall most common type of dementia. Alzheimer's disease is the most common type of dementia. Some of the important neurotransmitter changes which occur is, one is there is a decrease in acetylcholine. Glutamate is increased. Microscopically if we see, so if we try to correlate with pathology, microscopically we see that there are amyloid plaques, A beta deposits are there, and also neurofibrillary tangles. Now in this one slide we have mechanisms of 3 drugs. So based on the etiology we can also remember name of the drugs which are used. Okay, so let's try to correlate with the drugs. Again, psychopharmacology is a very important topic which they usually ask. 2 to 3 questions may just come from psychopharmacology. Now, so in the treatment, so let's try to correlate with the etiology. We know that there is a decrease in the acetylcholine. So we use a drug which are cholinesterase inhibitors. So basically acetylcholine is broken down into acetyl and choline. So what we do is we inhibit this enzyme. So what will happen? There will be increase in acetylcholine. So this is again we can correlate with the etiology. So some of the drugs such as tacrin. I hope you know all these drugs. Tacrin is not used because it is hepatotoxic. Other drugs such as donepezil. Can you name some of these drugs? Donepezil, rivastigmine, and galantamine. Okay. Now then next we also know that there is an increase in the glutamate. So we use a drug which is mementin. What is the mechanism of action of mementin? Can anybody tell me what is the mechanism of action of mementin? Mementin, very good, yes. Galantamine is, yes, cholinesterase inhibitor. What is the mechanism of action? Mementin is a NMDA antagonist. It is a NMDA antagonist. Now NMDA is basically a glutamate receptor. So we know glutamate is increased. Glutamate is excitatory neurotransmitter and excess of it is neurotoxic. So we are using an antagonist, mementin. Okay, so this is the second drug. Then we now have another drug, third drug, which is FDA approved. So we know this is especially for Alzheimer's dementia. So we know amyloid plaques are there. So we have a new drug, aducanumab. Can you remember? Yes, you can. Aducanumab. So the MAB is telling you it is a monoclonal antibody. It is a human IgG1 monoclonal antibody. And what it does is it helps in clearance of these A beta, the amyloid plaques which get deposited. It helps in their clearance. So which dementia it is treating? It is treating, the name is telling you, Alzheimer's dementia or Alzheimer's disease. Is it clear to everyone? This is a new drug, FDA approved drug for the treatment of Alzheimer's disease. So it is also known as targeted therapy. So the above 2 drugs usually help in just slowing down the progressions. Now we are saying it is treating the target or the cause, right? So this is again an important new drug. You should remember this. Is it clear to everyone? This is the treatment. Now this is one slide which I want all of you to remember. Again, this is an important topic, Lewy body dementia. Lewy body dementia, again it's a progressive dementia. Lewy body dementia now we say is the second most common overall cause of dementia. Earlier we used to say vascular dementia, but now we say that Lewy body dementia is the second most common overall cause of dementia. This is important. You should also know some important core features of Lewy body dementia. Again, these are questions which may come in your exam. First is there is fluctuating cognition. So cognitive impairment is there, that is fluctuating. Visual hallucination, we have discussed that visual hallucinations are more common hallucinations of organic mental disorders are visual hallucination. In fact, this is in the core criteria of Lewy body dementia. So patient having cognitive impairment, he is seeing someone although nobody is around, and the third is he has motor features of Parkinsonism such as tremors, rigidity, bradykinesia. So this clinical picture may be given: cognitive impairment, visual hallucinations and motor symptoms. What is the diagnosis? Lewy body dementia. And in microscopically what will you find? Microscopically, the name is telling you what will you find? You will find Lewy bodies. You will find Lewy bodies. But please remember, a very close differential diagnosis, a very close differential diagnosis of this condition is Parkinson's disease. Parkinson's disease. So we know in Parkinson's disease, we know there are motor symptoms. Parkinson's disease also may have dementia, so cognitive impairment and visual hallucinations can also be seen. So all these three features can also be seen in Parkinson's disease, and even Lewy bodies can be seen in Parkinson's disease. So a very close differential diagnosis of Lewy body dementia is Parkinson's disease. How clinically we differentiate Lewy body dementia with Parkinson's disease? So basically we say that in Lewy body dementia, the cognitive symptoms usually occur first, or if the motor symptoms occur, they occur together. So cognitive symptoms and motor symptoms, either they occur together or cognitive symptoms occur first. While in Parkinson's disease, there are motor symptoms first and then there are cognitive symptoms, and usually the difference is around 1 year. So if the patient has predominantly motor symptoms initially and after 1 year the cognitive symptoms are developed, then it is more towards Parkinson's disease. Otherwise the picture is very similar. Very good, yes. Is it clear to everyone? This is a very important point, may come in your exam as a question. Okay. Now let us come to this question, again a 2018 question. So such questions may come where we may have to just apply certain basic knowledge and we will be able to solve. All are used in the management of a violent patient in psychiatry except. So if a patient has become violent, so what all can be used? We have to say which is not used. So ECT, we know ECT is electroconvulsive therapy, sometimes it can be used. Benzodiazepine, yes, to calm the patient, to sedate the patient. And haloperidol also, it's an antipsychotic, first generation antipsychotic we often use to, in agitated patients. Cognitive behavior therapy, CBT has very good, yes Anju Devtaru, it is CBT, cognitive behavior therapy. Again, for it to, if you have to use CBT, the patient has to, be, following your instruction. Here the patient is very violent, so CBT is of no use in that situation. Very good. So answer is this. Now let me give you a FQ. So please remember, there was a new drug for, which was approved, in March, and the question came in INI-CET, which we had discussed earlier. Similarly, there is a new drug which has been approved recently. So this is again, and you are seeing this topic is very important. So let us try to answer. So the FDA approved drug. Can anybody answer this question? Agitation. So we know in dementia, neuropsychiatric symptoms such as delusions, hallucinations, depression, agitation, they can occur. In dementia, due to Alzheimer's disease. So normally if agitation occurs, we use we use some of the antipsychotics such as haloperidol, olanzapine. But now there is one drug which is approved for this particular condition. They may ask you this: a patient is agitated with diagnosis of Alzheimer's dementia. Which drug is FDA approved for this condition? Please mark this in your notes. This may come as a new question. So the drug is brexpiprazole. It is a second generation antipsychotic like aripiprazole. It is a partial D2 agonist. Please remember this very important drug which we are discussing, brexpiprazole. It may come as a new question. Please be thorough with such questions. Okay, brexpiprazole. Again I am highlighting, just remember this drug. If they ask this particular situation, it is approved by FDA recently. Is it clear to everyone? Again, this is an FQ. All are negative symptoms of schizophrenia. So we have covered organic mental disorder. Let us talk about psychotic disorder. Psychotic disorders. Okay, let's talk about psychotic disorders. Again, if you see, many questions have been asked from psychotic disorders. All are negative symptoms of schizophrenia except. So what is the answer? What is the answer of this question? Negative symptoms of schizophrenia. Anhedonia we have just discussed. Yes, it is a negative symptoms. Alogia. Logia, neologism. Logos means word. Alogia means decrease in the verbal communication. Decrease in the verbal communication. Avolition, volition means will, decrease in the motivation. Very good. Yes, all these are negative symptoms. Yes. Overactivity, very good. Yes, Deptaru, Anil, serotonin, Anju, dopamine agonist, very good. All of you are correct. It is overactivity. What are the other negative symptoms? So one is anhedonia. Anhedonia is the most common negative symptom. Then alogia is there, avolition is there. What are other symptoms? What are other symptoms? Affective blunting. Affective blunting, decrease in the expression. So this is again important, flat affect or blunt affect. This also you should know. What is flat or blunt affect? Okay, the expression, the decrease in the expression. Flat so means totally dead. So you talk about something, you know, happy, something sad, but the patient is not showing any changes in emotion. That is flat affect or blunted affect. So affective flattening. And the last is, can anyone tell me what is the last? Very good. Yes, serotonin. It is asociality. Very good. So there is decrease in the socialization. Family members say we take him outside, he does not socialize. We, you know, people come and meet him at home, does not socialize. So there is decrease in socialization. The drive to socialize decreases. So these are the 5 important negative symptoms. Everything is getting reduced. That is why it is known as negative symptom. Very good. Next question again, please have a look at this question. These questions we have been discussing and they are asking, it's maybe a newer question. So they are asking about this clinical symptom. A patient when asked what is his name, he repeats the same question again. What is your name? What is your name? So you ask, what do you do? He says, what do you do? Where do you live? He says, where do you live? So he is repeating whatever you are saying. Okay, he is repeating what you are saying. So what is this phenomena? This is your 2022 question. It is echolalia. Very good. Echo means to repeat. Lalia means word. So whatever you are saying, he is repeating. Let's see other options. Echopraxia. What is echopraxia? Remember, apraxia, movement. Echopraxia means the patient is mimicking examiner's movement. So suppose you are writing in front of the patient is having no pen and paper, but he also may start doing this movement, echopraxia. We will talk about perseveration, then posturing again. Posturing, patient is maintaining an abnormal posture. All these A, B and D, these are catatonic symptoms. These are catatonic symptoms. Again, catatonia is a very important topic. They have been asking many questions. So let us see some of the catatonic symptoms. Some of the catatonic symptoms. So the person may be in a state of stupor. He is not reacting. And he may be, you know, some may have opposite. They are very excited. They are not sitting. Non-purposeless activities they are doing. Mutism. Mutism, you know, just like you can mute a television as if you muted the patient. He is doing things but he is not speaking. Mutism. Look at this. Image based questions. Very good. Yes, image based questions are very important. So we will discuss some of them which have been asked. So look, a patient is maintaining an odd posture. It can either be catalepsy. Cataplexy is in narcolepsy. Narcolepsy mein catalepsy nahi hota. Please remember it like this. Or posturing. The difference is that if it is passive, that means someone else has made him come into this posture, now he is maintaining it, then it is catalepsy. Posturing is active, that is he himself have come into this posture. Okay, this is again important. Waxy flexibility. Person can be molded like a wax candle. So just like if you try to mold a wax candle, there is initial resistance, then you can mold the way you want. Similarly, let us say if this hand is of the patient and if you try to move, there is initial resistance, then you can later on move the way you want. This is waxy flexibility. All these symptoms, just like echolalia, they can ask you as a symptom. Negativism. Negativism, as if he is turned very negative towards the examiner. So he is giving you no response or he is opposing whatever you are asking him to do. So in the question they may tell you, you ask the patient to come forward, but he is going backward. So he is doing the opposite. This is negativism. While automatic obedience is just the opposite. here the patient is showing excessive cooperation. You tell him to do anything, he will do. You tell him, I will going to prick your tongue with this needle, and you tell him to pull out his tongue, he will pull out the tongue. If you prick his tongue, then also he will, later also he will pull out the tongue if you ask. This is automatic obedience. Mannerisms, stereotypies, these are odd movements, repetitive odd movements. Mannerism beta naam mein hai, in the name there is manner or purposeful. These are purposeful movements. So like this. So patient is repeatedly doing this movement. This is a salute movement. It is a purposeful movement. While stereotypies are non-purposeful movements. No purpose. Any movement like this. Even in Rett syndrome we'll discuss midline movements like this. They may be seen. These are stereotypy. Grimacing. What is grimacing? Nowadays what you do if you take a selfie, what you do? You pout. And if you maintain it for a long time, that is grimacing. Grimacing kya hai beta? Maintaining odd facial expressions. Lastly, ambitendency. Ambitendency means inability to decide a movement. For example, if there is a pen on the table, patient's hand is going forward, backward, forward, backward. He is not able to decide should he pick it up or not. So there is inability to take decision at the movement level. Okay, so is it clear to everyone beta? These are some important catatonic symptoms. We already have discussed these two. So these are some important catatonic symptoms. What is the treatment of catatonia? What is the treatment of catatonic symptoms? What is the treatment of catatonia? This also is very, very important. Please remember, first line treatment is IV lorazepam. Okay, if the person does not improve, or the best treatment then we can give is ECT, electroconvulsive therapy. Again, catatonia is very, very important. Please see, it's an old question, even older, I think before 2018. So it's an old question, but see, which of the following is seen in catatonia? Again, they are played with words. Can you tell me? Can you tell me what is the answer? Can you tell me? Yes, serotonin, it was lorazepam. Now can you answer this question? Venju, yes, it was ECT. Now can you tell me the answer of this question? See the options and let's try to answer. They played with words. What is the answer? Very good. It is not cataplexy, it is catalepsy. It is not positivism, it is negativism. It is not disobedience, it is automatic obedience. So look, they have initially asked just about echolalia. Now they have recently asked a clinical picture. So such type of questions may be asked. Now let's talk about, so I've told you, perseveration was there in the option. So let's talk about what is perseveration. Again, put a FQ. This is an important topic. FQ. What is perseveration beta? It comes under disorder of flow. It is problems in continuity. P for perseveration, 3 P's you can remember. Thought persist beyond the point of relevance. One thought is repeating again and again. Okay, perseveration is, it is repeating again and again. For example, I am given you a scenario also. So you ask a patient, what is your name? He says, my name is Mukesh. It is correct. Now you say, what do you do? He says, my name is Mukesh. It is not relevant now, but he is saying the same. Where do you live? My name is Mukesh. So he is repeating the same thought again and again. This is perseveration. Echolalia kya hai beta? What is your name? What is your name? What do you do? What do you do? So perseveration is an important topic. Can anybody tell me where will you find perseveration? 2 important conditions I want you to remember. Where will you find perseveration? One is again organic mental disorders. In organic mental disorders. Yes, very good, Shakti, very good. It is organic mental disorders. Other is even you can find it in schizophrenia. You can also find it in schizophrenia. Very good. Is it clear to everyone? Right. Now let's talk about the next question. Again, this is your 2023 question. 2023 question. The last exam question. A patient of 27 years old presented with complaints that aliens are communicating with him. They are sending electromagnetic radiation to his brain and aliens are asking him to kill the distant relatives. His relative says that he has this disease from the last 20 years. So since childhood only he is having this disease. The patient does not work on his farm now and also he has stopped going in social functions. he is aware of time, place and person, matlab he is oriented. What is the likely diagnosis? What is the diagnosis here? Can you tell me? What is the diagnosis? Is it delusional disorder? Okay, so first we know it is not depression, it is not mania. Okay, it is not depression because there is no mood symptom. We'll come to that. Okay, we'll talk about paraschizophrenia. So this is the answer. So please see, he says, so it is telling you that they are, asking him. So they are trying to communicate. That means it appears that he is having hallucinations. He is having hallucinations. Most likely these are auditory hallucinations. He has stopped going to functions. There is asociality. There is asociality. Please see the duration. It is 20 years. So there are hallucinations, there are negative symptoms in a patient for more than 6 months. So what is the diagnosis here? What is the diagnosis? It is schizophrenia. It is schizophrenia. Also please see, he stopped working also. What is happening to his functioning? But a patient की functioning कैसी है? Functioning means his occupational or his social functioning or his self-care. Functioning कैसी है बेटा? How is the functioning? He has stopped going to work. Functioning seems to be severely impaired. Functioning seems to be severely impaired. Even if you have doubt, sir ये hallucination है, delusion है, please see the functioning. Usually we say in schizophrenia the functioning is impaired, while in delusional disorder the functioning is not that much affected. Okay, so in delusional disorder they would have said you that patient is going to work, doing things. Functional impairment is more seen in schizophrenia. Very good. So this is again telling you that it is schizophrenia. Let's talk about schizophrenia beta criteria. So schizophrenia, there are 5 important symptoms, again according to DSM-5. One is delusion, it's a false belief we have discussed. Hallucinations, again hallucinations are false perception without any stimulus. These can be auditory hallucination, visual, these can be tactile, olfactory and gustatory hallucination. Catatonic behavior or grossly disorganized behavior, again we have discussed catatonic symptoms and negative symptoms. So we've discussed all these symptoms. Now to make the diagnosis of schizophrenia, we say 2 or more symptoms out of the 5 should be present, but at least 1 symptom should be from the first 3, and total duration of illness is at least 6 months. Okay, 6 months. Very good. So is it clear now beta? The patient is having hallucinations. Even if other symptoms are not there, there is no diagnosis when he is having hallucinations. So we don't have other diagnosis. Okay, it is more than 6 months. Here in the question it is 20 years. This is schizophrenia. So this is the criteria of schizophrenia. Is it clear to everyone beta? The criteria of schizophrenia, again very important topic, schizophrenia. Please remember this. Is it clear to everyone? Any doubt still? Somebody had asked for, Paras had asked for, explaining schizophrenia. Paras, is it clear to you? Schizophrenia. Is schizophrenia clear to everyone? The 4 A's of schizophrenia, what you're talking about, Paras, those were basically, those were Bloiler's 4 A's. Okay. When you read Bloiler was the person who had coined the term schizophrenia, and he gave 4 A's. Can anybody tell me? Okay, let us discuss briefly these 4 A's. Can anybody tell me what were the 4 A's which Bloiler discussed? One was affective disturbances such as loosening of association. We have discussed what is loosening of association, but it is a disorder of form. Then affective flattening. We have discussed flat affect. Then he also described autism. Autism means person is having fantasy thinking and behavior. And the last is ambivalence. Beta catatonia mein we have discussed tendency. Ambivalence matlab inability to take a decision at the thinking level. Tendency is to take a decision at the motor level. For example, patient is staring at the pen for a long time. He is not able to decide whether he should pick it up or not. This is ambivalence. These are Bloiler's 4 A's. This question has also been asked quite long back. They had asked this question also. Which of the following is not a Bloiler's 4 A symptom? This is again history. If you read of schizophrenia, these are the 4 A's. Now is it clear beta? Now is it clear to everyone? This is very good. This is Bloiler 4A. These are the 4 A's which we say. Negative symptoms, you can say, we don't say it as 5 A's, but these are the 5 important negative symptoms. I hope this is clear now. Right. Now, next question, 2020 question. A 15-year-old girl, after failing in her exams, started hearing voices abusing her since few days and started doubting that her school teachers have conspired against her. Dekho beta. So, what is this phenomena that she is hearing voices? She is hearing voices. This is hallucination. What hallucination? Auditory hallucination. She is also doubting that the teachers have conspired against her. So, this is beta delusion. Here it seems it is delusion of persecution. But look at the duration. Duration is only days. Duration is only days beta. So, symptoms are like schizophrenia, but it is not fulfilling the duration criteria. तो बेटा इसको क्या कहेंगे? In delusional disorder, I'll come to that. There are only predominant delusions. Here they have delusions and hallucinations. So the answer is acute psychosis. But the answer is acute psychosis. What is acute psychosis? It is a psychotic disorder in which symptoms are similar to schizophrenia, but duration is less than 6 months. And many a times you get some stressors. There may be some life event. There may be some life event, like in the case of the patient has failed in an exam, or sometimes even fever may occur. Fever may be there at the onset. So this is acute psychosis. Very, very important to differentiate. This is acute psychosis. Is it clear to everyone? Now, one more point I want you to remember beta. The second option we have discussed beta, delirium. Delirium also occurs, has an acute onset. And many times in delusions also, in delirium also you may get delusions and hallucinations. And fever also is, may be present in delirium. It's an organic mental disorder. So how will you differentiate delirium from acute psychosis? Please see, both of them have acute onset and fever. Suppose I would have given fever in the option, then we might have get even more confused that it may be delirium. Can anybody differentiate delirium from acute psychosis? How will you differentiate? Can anybody tell me? Can anybody tell me how to differentiate delirium from acute psychosis? Schizophrenia नहीं हुआ because schizophrenia होता है 6 months से ज़्यादा duration होना चाहिए. Here the duration is only in a few days. Look at this. So उन्होंने days, only few days से symptoms हैं. That is why Dr. DD, it is not schizophrenia. Okay, is it clear? So how will you differentiate? Anybody? अभी हमने discuss किया. Very good, serotonin. Very good. In delirium, very good. There is impairment of consciousness. I have told you important points, terms which they may tell you in the question. Suppose here they would have added confusion, that since few days the patient is also appearing confused, then the answer would have been delirium. But there is no impairment of consciousness mentioned, so that is why the answer in the question is acute psychosis. Is it clear to everyone? This is very, very important differential diagnosis. Next question, 2021 question. Now let's see this question. A patient since 3 months, he believes that his daughter wants to kill him. Very good, Anju. Yes, LOC, not LOC, but impairment of consciousness, like time, place and person. Very good. So patient believes that my daughter wants to kill me. What is the diagnosis? Now tell me the diagnosis. So all these questions are your exam questions. You should be aware of these questions. Now tell me the answer of this question. Very good. Look, the patient has only delusions. There is only a delusion that my daughter wants to kill me. Delusion of persecution. So it is not schizophrenia. Duration also is 3 months. Xenophobia is fear of strangers. It is a specific phobia. We'll come to that. Bipolar disorder. No, it is delusional disorder. Very good. Yes, Ria, Bhavnesh, dopamine agonist, serotonin. Very good. Yes. Yes, Anju. It is delusional disorder. So what is delusional disorder? The name is telling you only delusions. Usually one or more delusions. It may be one or many delusions, delusion of persecution, reference, many may be present. Hallucinations are usually absent or they are transient. But if a person is having continuous hallucination, then it is not delusional disorder. And functioning, I have already told you, the functioning is is less affected, less impaired. So in this question, although it's just a one-liner, they would have said that he is going to his office, he is meeting people, he's just that he is afraid of his daughter. Only some some degree of impairment at that level where there is delusion, he is impairment. Otherwise all other domains of life he is functioning nearly normal. So this will differentiate it from schizophrenia. Is it clear to everyone? Is it clear to everyone? Yes, Anju, that was phobia, xenophobia. Now, let's come to the next question. So we have covered important psychotic disorders. So if you can see, many recently questions have been asked. Now we are discussing important topics from mood disorders. In fact, when you will see questions from mood disorder, you will see a lot of questions clinical as well as a lot of questions on treatment have been recently asked. So I'm trying to tell you some important areas in which you should focus. We have limited time, so you should focus on these areas. A female was brought to the psychiatrist 5 weeks after her delivery. She appeared fearful, irritable and having suicidal thoughts. What is the likely diagnosis? Beta? Blues, psychosis postpartum, postpartum depression or panic disorder. Very good. It is not blues, it is not psychosis, it is not panic disorder, it is postpartum depression. Very good. It is postpartum depression. Again, pregnancy and psychiatry is very important area which they are asking questions. Many questions are coming in this area. So again, you should be thorough with these questions. So let's try to let's try to understand three important terms: postpartum blues, postpartum depression and postpartum psychosis. Blues, usually when you see, listen to some in the movies, somebody sad, they play this song feeling blue, so blue is related with this sadness. It occurs in 30 to 75 percent of the females who have given birth or delivered a baby. Onset is usually 3 to 5 days after the delivery, usually early it occurs, and there are transient symptoms. Symptoms are transient, okay, transient. Sadness, irritability, the person is very tearful, or decreased sleep. So such symptoms are there which are transient symptoms, not very severe symptoms. Do you have to do any specific treatment for postpartum blues beta? Postpartum blues की कोई अलग से अपने को treatment करनी है? No, there is no specific treatment, no treatment required, just give supportive care, and as we discussed, the transient symptoms हैं, these will improve. Okay, then next is postpartum depression. Very good, no, not required. It is seen in 10 to 15% of the females after delivery. It may occur during pregnancy or 6 weeks of delivery. Okay, so sometimes it is known as peripartum onset. Now patient have symptoms of depression and more severe symptoms such as anhedonia, suicidal thoughts, excessive guilt. These symptoms are present. So this is postpartum depression. Patient in the question had suicidal thoughts. It is not blues anymore. It is postpartum depression. Now, what is the treatment? Again, we can treat with drugs such as SSRI. We can do CBT. We'll talk about that. Also, there is a new drug which is FDA approved. Okay, brexanolone. Brexanolone is a drug which is approved for this condition, postpartum depression. What is brexanolone? It is a GABA A modulator. GABA A modulator. Okay. Is it clear to everyone? So this is postpartum depression. Usually they have asked questions on depression, and blues. Now in postpartum psychosis, less questions have not been asked, many questions. So let us know what is postpartum psychosis. It occurs in 0.1 to 0.2%, even lesser. So along with certain symptoms like irritability, anger, sleep disturbance, patient has delusions and hallucination. Delusions and hallucinations are known as psychotic symptoms. So patient may say that this baby is not mine, I have not delivered any baby, or she may say that I am hearing voices to kill the baby. Such types of delusions or hallucinations may be present, and if delusions and hallucinations, it is postpartum psychosis, you would have to add antipsychotics. So they may also ask the treatment. So you have to add antipsychotics. Is this clear to everyone? Is this clear to everyone? Is it clear to everyone? Let me know, because this is very, very important. Okay. Now, neurotransmitters involved in depression include, it's a 2018 question, etiology, you know, they've asked this question. So what is the answer of this question? What is the answer of this question? Can anybody tell me? Very good. Yes, Paras, Riya, Anju, good. So let us try to answer this question. Very good. So this is, you know, the option is all is there, so it is all. What is this hypothesis? Can anybody tell me what is this? There is one hypothesis. So what is this hypothesis known as for depression? It is monoamine hypothesis. Monoamine hypothesis. Okay. If you have to choose two neurotransmitters, then if you have to choose two neurotransmitters, then serotonin and norepinephrine are the important ones. But here they have asked, you know, all option is given. So then it is, you know, all. So there is a decrease in these neurotransmitters. This is monoamine hypothesis. Can anybody tell me for which disorder we have dopamine hypothesis? Dopamine hypothesis किस disorder के लिए है बेटा? Monoamine hypothesis we have discussed. Very good. Yes, it is all. For which disorder we have dopamine hypothesis? It is for schizophrenia. In schizophrenia it is said that there is an increase in dopamine. So we use antipsychotics which are D2 antagonist. Okay. So this is dopamine hypothesis for schizophrenia. Very good. Now let's come to this question. Again, it's a recently asked question, but let's try to see what type of questions they are asking. A lot of clinical treatment related questions. Okay, yes, it was schizophrenia, right? Now, a patient is diagnosed with mild depression. Which of the following is the treatment of choice? What is the answer? Again, related to treatment. Usually when we treat a patient with depression, usually we use SSRIs, and we can also use CBT. Okay, but they have specifically asked you mild depression. When they say specifically mild, in mild cases, and let us say in moderate to severe, so in mild cases you may start CBT. So in mild cases, this is a way of asking you, you know, the symptoms are mild, what will you use? So we may use, otherwise in moderate to severe we may have to start SSRIs along with, if required, CBT may also be started. Okay, overall we may say drugs, but they have asked you specifically mild, so the answer is CBT. Again, this is very such type of question, don't make a mistake, especially in the treatment. Now, so in the treatment, as I said, a lot of questions have been asked on, you know, the drugs. So in, you know, in the treatment of depression, the drug of choice is SSRI. So I mentioned some of these SSRIs like sertraline, fluoxetine, paroxetine, citalopram, escitalopram, vilazodone. So some of the side effect, most common side effect of these drugs, of the SSRIs, is nausea. It may have other side effects such as diarrhea, constipation, dry mouth. It causes dry mouth and not hypersalivation. One of the questions in some other exam they had asked. It is dry mouth and not hypersalivation. Sexual side effects, yes, it can cause. These are the most common long-term side effect. Most common long-term side effects of SSRIs are sexual side effects such as decreased libido, delayed ejaculation. Some other side effects like vivid dreams, sweating, hyponatremia, especially in elderly, may occur. So these are some of the side effects of SSRI. Does SSRI cause sexual dysfunction? Yes. They cause sexual dysfunction. Yes. Okay. ECT, I'll talk about ECT, when we can use ECT. Okay. So this is important. Is it clear to everyone? Now, one more point about this you can remember. In pregnancy, which SSRI is contraindicated? In pregnancy, can anybody tell me which, yes, weight gain is also there, very good. Dryness is there, yes. In pregnancy, which SSRI is contraindicated? P for paroxetine, contraindicated in pregnancy. It causes teratogenic effect, cardiovascular defect in the baby. So paroxetine is contraindicated. Please remember this. Another question which may come as a new question. Okay. So this is again important. Is it clear to everyone? Now, in your exam, a question recently came, you know, I think 2021-22 question came that a psychiatrist is starting a treatment for a patient of depression, and the drug affects serotonin, as well as norepinephrine. This is FMG exam question, PYQ. What is the drug? Simply they were asking you which of the following is a SNRI. So SNRI means serotonin norepinephrine reuptake inhibitor. The answer in the option was venlafaxine. So we have venlafaxine, desvenlafaxine, duloxetine, milnacipram, levomilnacipram. These are some of the SNRIs. Does SNRI cause sexual side effect? The side effects of SNRIs are similar to SSRI. So yes, even SNRIs also cause sexual side effect. One important side effect of drugs such as venlafaxine, you can remember, another side effect is hypertension. So try to add these points. So if you don't know, try to add these may come in the exams as well. So SNRI, okay, this is your recently asked question. So if you see many questions they are asking on the drugs, on the effect, on the side effects. Now next question, again this is your 2023, your the last exam which occurred. Again if you see question on the drug, a 35-year-old man was taking medication for depression, but he has developed sexual dysfunction. Which of the following drugs should you switch to address this problem? Can anybody tell me what is the answer? Can anybody tell me what is the answer of this question? What is the answer of this question? So answer, which drug will have less sexual side effect out of these? We have discussed escitalopram is a SSRI, it causes SNRIs also, even TCAs also have sexual dysfunction. Yes, very good, very good. It is bupropion. It has less sexual dysfunction. Again, few points about bupropion, many questions have come. So bupropion is a NDRI, it is norepinephrine dopamine reuptake inhibitor. Okay, so it has low risk of sexual dysfunction. It is one of the drugs with less sexual dysfunction. Can you tell me another drug with have less sexual dysfunction, another antidepressant? You should remember, this has been also asked in various exams, mirtazapine. Even mirtazapine has less sexual dysfunction. So this is bupropion. Side effects, one important side effect is seizures, especially at higher doses. So again an FQ for you, that bupropion is contraindicated in which disorder? It is contraindicated in disorders such as bulimia nervosa, anorexia nervosa, which have, so there the patient is already at risk of seizure. So you should avoid, you should not give bupropion in these patients. Very good, Anju. Yes, it is also a PYQ of FMG. Antidepressant used for smoking cessation. We'll come to that. Smoking cessation. This question has also been asked. This is also a PYQ. So again, bupropion is an important drug. Okay, is an important drug. Is it clear to everyone? One point also you can add down, which antidepressant can have side effect such as priapism. Anybody knows priapism? Priapism is basically painful erection. Which drug has this side effect? You can write down trazodone. Please write down trazodone. Okay, trazodone has a side effect of, you know, painful erection, right? Now let's come to this question. Again a 2020 question. A 30-year-old female presents with 5 episodes of mania, hypomania and depression in the last 1 year with complete recovery in between the episodes. So what is the diagnosis, beta? The diagnosis is bipolar disorder. The diagnosis is bipolar disorder. So in bipolar disorders, patient have episodes of depression, mania or hypomania with inter-episodic. In between the patient becomes all well in the episode. So diagnosis is, what is it? It is rapid cycling bipolar disorder. Very good. So what is rapid cycling? Beta, rapid cycling means the symptoms are going up and down rapidly. So rapid cycling bipolar disorder means 4 or more episodes of depression, mania or hypomania in 1 year. Here he was having 5 episodes, so it is of course more than 4. 4 or more is rapid cycling. So suppose this is 1 year duration, and the lower symptoms are depression, above symptoms are mania and hypomania. So let us say this patient had episodes like this. Okay, so this is what this is, the rapid cycling, and in between if you see, the patient is all well. In between he improves. This is rapid cycling. Now one more extra question for you, you can add down. Can anybody tell me what is the treatment? Which drug is used for rapid cycling? Which is the drug which is seen to have good effect? Good effect. So basically for mania or hypomania, okay, we have drugs such as antipsychotics, lithium and valproate. Okay, usually these are the first line drugs. Okay, usually say any of these we can use. Sometimes we may prefer antipsychotics. Okay, and in pregnancy if they ask you in mania which drug is preferred, it is of the same order, antipsychotic over lithium, and usually you should avoid valproate. Okay, because valproate causes neural tube defect. Even lithium causes teratogenic effect. Abstin anomaly we'll discuss. Okay, so these are some of the drugs we use in mania. Okay, lithium, valproate are mood stabilizers. Now the question, I'll come back to this question. Come back to this question. So this question is, treatment is, beta, which drug is used for rapid cycling? Valproate is shown to have good effect. Has shown to have good effect in rapid cycling. So this is an extra edge question you should know. Okay, is it clear to everyone? So we use valproate, more preferred. Now this one option which is emotionally unstable personality disorder, it's a term, it's a name also, this is also described as borderline personality disorder. So briefly just I'll tell you, because again I feel it's an important topic. It's a personality disorder. It is a cluster B personality disorder. It is more common in females than males. So in personality disorder, usually patient has a long standing symptoms which usually start somewhere between late adolescent or early adulthood, and these symptoms usually continue, remain stable through time. This is how a patient with personality disorder would come. So what type of symptoms? Patient has unstable relationships. Person says, someday the person may say that you are my best friend. On another day patient may say you are the worst person I know. So their relationships are unstable. They are very impulsive. They may do things without thinking about consequences. Recurrent suicidal behavior or threats may be given. Their mood is unstable. So this is borderline personality disorder. So please just know this. And one more point is treatment for personality disorder. Usually we do therapy, especially for borderline we have dialectical behavior therapy or DBT. Please remember this point. Okay, please remember this point. Is it clear? So I'm just trying to give you some extra points also so that it becomes useful. Now this question again, it's an old question. So let us discuss what is double depression, asked in 2018. What is double depression, beta? So let's try to answer. What is double depression? Options are depression for 2 years, depression with anxiety, depression with psychotic symptoms, or depression with dysthymia. Depression with psychotic symptoms is known as psychotic depression. So patient developed symptoms of depression, and then later on patient also developed delusions or hallucinations. Here we do treatment of antidepressant plus antipsychotics. So treatment is by both. So it is not C. Very good. Double depression is dysthymia with depression with dysthymia. So let's try to see what is double depression with a dysthymia. It is a disorder having depressive symptoms. So presence of mild depressive symptoms. We are not saying that patient is having mild depression. For mild depression, he should fulfill the criteria of depression. Here, there are only few depressive symptoms which are not enough to make a depressive episode. But duration is 2 years. So patient is for 2 years, he's experiencing these mild depressive symptoms. Since they are mild, the patient says functional impairment is not severe. Sir, I am going to my office, I am doing my work, but since 2 years I am feeling these mild symptoms. What is the diagnosis? It is dysthymia. Let's try to understand with this graph so that things become very clear. Let us suppose that if the patient touches this line, that means a depressive episode is, can be made. So let us say this is 2 years duration. So patient may say that there are days when I am feeling sad or there is decreased energy, and these symptoms are continuously occurring since 2 years. So if you see throughout these 2 years, there have never been a point where the symptoms are zero. Continuously patient is having symptom, but he has never touched this line. That means symptoms are not severe enough to make a diagnosis of depressive disorder. This is dysthymia. Now, in dysthymia, suppose now a patient actually develops a depressive episode. This is what is known as double depression. Dysthymia followed by depression. So this is double depression. Is it clear to everyone? This is double depression. Is it clear to everyone, beta? Is it clear? Right. Now again, this is an old question. Copycat suicide is seen most commonly in. Copycat means beta copying someone, mimicking or copying the method of suicide. Copying the method of suicide. So suppose there is news in, there is a news in TV that a, celebrity has committed suicide by hanging. So maybe, some person also seeing that method has also committed suicide. So he has copied the method. This is copycat suicide, mimicking the method of suicide. It is more common in adolescence. Please write this down. It is more common in adolescence. Is it clear to everyone? It is more common in adolescence. Now let's come to the next question. So we have covered important questions which have been asked in mood disorders. Now we'll be talking about anxiety disorders. In anxiety disorders, if you see, many questions have been asked, especially related to panic disorders. Many questions have been asked in the recent past. And in fact, mostly in most of these anxiety disorders, they have questions about. So let us try to see the question. Let us try to see. Very good. Yes, all of you have marked correctly. Okay. Okay. So this is correct. A 30-year-old female presents with sudden onset of chest pain, palpitations, with feelings of impending doom, which is lasted for 20 minutes. She had 3 similar episodes in the past. Investigations are normal. So that means it does not suggest any physical disorder. It was asked in 2019. But what is the answer? Yes, insight is present in anxiety disorder. Yes, it's a neurotic disorder. Yes, correct, Anju. Yes, Kuldeep, correct. Yes, it is a panic disorder. Very good. Ria, Dr. DD, dopamine agonist, serotonin, Krishna Kumar, Priti, Surila. Yes, all of you have marked it correct. Yes, Himanshu, it is panic disorder. Let us try to understand some of these anxiety disorders. So there are 5 anxiety disorders. What I have done is I have clubbed them in 2 categories. One is panic disorder. Panic disorder means patient has recurrent panic attacks. In panic attack, what happens? Patient has sudden onset of severe anxiety. Oh my God, something is happening. Palpitation, chest pain, breathlessness, with a feeling of impending doom. Oh my God, I am about to die. Fear of dying. But these episodes last for 20 to 30 minutes usually, and they can occur in any situation. So they are unexpected. So this is how panic disorders would occur. If you see in between, patient is normal. This is how panic disorder would present to us. Panic disorder is very important. We'll discuss more questions. Another is generalized anxiety disorder. Here, as the name suggests, we see there is persistent anxiety. Patient is worried on small things. Oh my God, my husband is late from office. My children are late from, from the school. So the person is, anxious about small things. There is excessive worries. If you draw it, GAD would occur like this. Patient is continuously having, small anxieties. Patient is having minor anxiety, but it is occurring continuously. In panic disorder, severe anxiety. Okay, so panic disorder can occur, anywhere. Generalized, it is occurring, continuously it is occurring. And in between, we have situational anxiety. Anxiety occurring only in particular situations, like agoraphobia, specific phobia, social phobia. We'll come to that. Now, so that was the answer is, so if you can see, patient is having episodes with feeling of impending doom. The answer is panic disorder. Very good. Now see, Even in 2021 they had this question, but what they had done nowadays, what they do is they give you certain information which you know, which you may think of two diagnoses may come in your mind. So they have said that a patient is having COVID infection 3 months back, now presents with sudden onset of chest pain, palpitations with feeling she is about to die. These episodes last for 20 minutes. Investigations are normal. Now what is the answer? Can anybody tell me what is the answer here? What is the answer, Kuldeep? Is it PTSD? Yes, that is what I want to tell you, beta. COVID infection unhone de diya, so many of the students had marked PTSD. But please remember this. Look at the symptoms. We'll talk about PTSD, but here the symptoms are typically of, so patient is having symptoms of what? Patient is having symptoms of panic disorder. Sudden onset of chest pain, palpitation and feeling that the person is about to die, or if you know, they may say that person is feeling that I am having a heart attack, but investigations are normal. That means there is no physical cause. Okay, even with COVID, beta, patient can develop certain psychiatric disorders. So don't just see the stressor, see the symptoms. This is a very, very important point which I want you to understand, that sometimes some hints may tell you some other diagnosis, but look at the symptoms, look at the clear picture. Is it clear to everyone? Is it clear to everyone? Ria, Anil, very good. Dr. Tavseef, Anurag, don't worry guys, just focus on the questions, don't worry. Just focus on the question and understanding. Don't worry. Thank you, Deep, but don't worry, let's just understand the questions and you understand the basic. Any doubts you have, we'll follow that. Okay, good. So again I'm telling, look at this. Again recently this question is asked. So I'm telling you these are very important topics. Not a symptom of panic attack. Not a symptom of panic attack. Tremors, palpitation, suicidal thoughts, sweating. Okay, what is the answer here? Can anybody tell me what is the answer of this question? Very good. The answer of this question is suicidal thoughts. It is not. Suicidal thoughts kahan milenge beta? Suicidal thoughts nahi. Baki sab symptoms of anxiety hai, they can occur in panic attack. Suicidal thoughts will be seen in depression. Will be seen in depression. Okay. Is it clear to everyone? Very good, Anil, Himanshu, Anju. Yes, very correct. Now, let us come to again, beta, still see so many questions they have asked. This is a very interesting question. A woman is having sleep disturbances at night. She was afraid that her parents may die in a car accident. Diagnosis. Okay. What is the diagnosis? Again, again they have given some car accident thing. So again we may think otherwise, हम कुछ और सोचने लगेंगे बेटा, but please see. It is excessive worries. Very good, very good. It is GAD. Very good. Yes, Krishna, Dr. Vineet, Dr. Mohit, Sai Chandan. It is not OCD. I'll talk about what is OCD. Yes, Aswati, Anju. Yes. But they have not said that a car accident has happened. So why it will be PTSD? No, it is not PTSD. In PTSD, the trauma has to occur. They are saying that she is worried. I told you, beta, excessive worries. Excessive worries is GAD. Is it clear to everyone? Yes, it is GAD. Now look at this, beta. Now I told you that there are 3 disorders under the phobia or situational anxiety. You can think agoraphobia, specific phobia and social phobia. Beta, what is agoraphobia? If there is anxiety in 2 or more of the situations. There are 5 situations. If someone has anxiety in 2 or more situations, we say agoraphobia. Such as, what are these situations? Public transport. Sir, I get anxiety while using a train. I don't use any train. I don't travel in bus because I develop anxiety. In open spaces, big open spaces, I cannot go. Or in closed spaces such as lift, or in theaters, I cannot go. In crowded places or in a line, I cannot go. Or I cannot go alone out of my home. I need someone. So this is agoraphobia. If anxiety occurs in 2 or more of the situations, it is agoraphobia. Specific phobia means specific. So there is fear of a specific object or situation. There are many named phobias. Allurophobia means fear of cats. Acrophobia means fear of heights. Claustrophobia means fear of closed spaces. Nyctophobia means dark. Cynophobia means dog. These are some of them. Okay. while social phobia or social anxiety disorder is fear of social situation. Like, you know, I cannot go in a party, I cannot go in a wedding, I cannot go in a conference because patient is fearful of social situations, because there is fear of embarrassment. What if I do something which will embarrass me in front of others? Is it clear to everyone? Again, look at such a nice question they had framed in your exam. This is again a FMG PYQ. So it is a PYQ. A patient has fear of using a lift and avoid it and use stair instead. But what is the diagnosis? Again, you may get confused between two options. What is the answer here? What is the answer? So usually we treat these phobias with therapy. We treat these phobias with therapy. What is the answer, beta? Is it agoraphobia or specific phobia? This is I want to know. So I am telling you whether it is A or B. Tell me. Beta, it is only one situation. Remember, agoraphobia has to be two or more situations. So the answer is specific phobia, like claustrophobia. So this is what I want you to understand and remember. It's a beautiful question framed in your exam. Please remember this. Is it clear, beta, कि agoraphobia क्यों नहीं है? Agoraphobia is it has to be in two or more situation. Beta, close space यहाँ पे भी है, and even here also we know it is close space. If it is two, one more situation might have occurred, then we would have made a diagnosis of agoraphobia. Phobias usually we treat with therapy, okay, such as systematic, you can write down, systematic desensitization. This is the therapy of choice. This is the therapy of choice, okay, systematic desensitization. Is it clear to everyone? Simple questions, just you have to know the basics and you will solve them. A patient has, now we have covered anxiety disorders, let us talk about obsessive compulsive disorders and other disorders associated with it, okay. Is it clear to everyone up till now? Is it clear? A patient has excessive fear of contamination, repeated washing, repetitive doubts and repetitive checking behavior. Simple direct question, I think. There is, you know, contamination and there is, yes, others also therapies we use, Anju, very good. The answer to this question is OCD. Again, OCD is a very important topic. Please be aware of this topic, very, very important. Yes, we are covering these neurotic disorders now, right? Now, so what is OCD, beta? Obsessive compulsive disorder. Obsession is a disorder of, we have discussed, possession of thought. So obsessions and compulsions, you can remember it with the mnemonic ROSY. What are obsession, beta? Recurrent thoughts, repetitive recurrent thoughts, images or impulses. Like in the patient is having excessive thoughts that my hands are dirty or there is dirt around me. There is repeated thoughts. Patient know that these are my own thoughts. Patient knows that these are my own thoughts, but the patient knows that these are senseless, irrational thoughts. The patient cannot control these thoughts. So these are irresistible. Repetitive thoughts which are not controlled. Okay, so there are various types. I'll discuss some very interesting questions which are asked in your exam. So this is obsession. But what is compulsion? As the name suggests, the patient is doing repetitive acts. Patient is doing some repetitive acts. So if the patient is having repetitive thoughts that, you know, my hands are dirty, the patient may also start go and wash it. It's not that after washing once the patient will be satisfied. These may occur multiple times. Okay, so this is repetitive behavior, repetitive acts. This is compulsion. Okay, patients can have only obsessions, patients can have only compulsions, and patients can have both. Okay, so patients can have only obsessions, only compulsions, and both. Now, what is the most common comorbidity? This is an extra question. Please write this in your notes if you don't know. Which is the most common comorbidity with OCD? Can anybody tell me? OCD, comorbidity का मतलब है बेटा, co मतलब एक साथ, morbidity मतलब illness. Which other psychiatric illness you may also find in patients with OCD? Patient is in distress, beta. He knows it is wrong thoughts, but he is not able to control. Very good, Shakti, very good. It is depression. Yes, dopamine agonist, very good. Kuldeep, again, very good. It is depression. It is depression. So please remember this point also. Is it clear to everyone? Now, obsessions and compulsions can be of various types. Let's try to discuss, because sometimes they just give you a clinical situation. इसी पे question आ जाएगा बेटा. Most common, you should know, most common obsession is contamination. that patient has thoughts that my hands are dirty, things around me are dirty, contamination. Second is pathological doubts. Patient को doubt है whether I have switched off the lights, whether I have bolted the door. Female comes out of the kitchen and has doubt whether I have turned off the gas knob. So ये pathological doubts आ रही है multiple time. Person को पता है कि ये this is a wrong thought. I know I have switched off the light, but these doubts are occurring again and again. Okay, so there was a question in another exam that most common obsession, और उन्होंने contamination नहीं दिया option में, then it is pathological doubt. Symmetry, everything should be symmetrical. My pen, my books सब symmetrical होना चाहिए. Aggressive, aggression, obsession. Sir, I am getting repeated thoughts to hit the person standing in front of me, but sir ये मैं नहीं करना चाहता. These are wrong thoughts, but I am not able to control. ये क्या है? Aggression, obsession. They may give you such clinical scenarios. Yes, Anju, checking. We'll talk about that. Then sexual. Sir, I am getting repeated thoughts to touch the opposite gender inappropriately, but sir this is a wrong thought. I don't want to do this, but I am not able to control. This is again, so they may give you such clinical scenarios also, and of course it can be multiple. ये है obsession. ये है obsession. Yes. Now let's talk about compulsion, beta. Which is the most common compulsion? C for compulsion, C for checking. So जिस patient को pathological doubts हैं, अब वो क्या कर रहा है? He is coming and checking the door, checking the lights, checking the gas knob again and again and again. So this is checking. Second most common is washing. जिसको contamination है, the person is now washing his hand multiple times, 20, 30, 50 times. एक घंटे patient is just washing the hands. Okay. Then symmetry, patient is doing everything symmetrically. So patient हर काम symmetrically कर रहा है. So someone who is doing it symmetrically, तो उसकी जो speed होगी वो बढ़ जाएगी. It will be fast or slow. जो वो activities करेगा, there will be slowness. There will be slowness. Counting, patient is doing things in counts. So whatever he is doing, he is doing in counts. Multiples of 5, 10. So he is doing in counts. These are some important compulsion. Of course, there can be multiple. Please remember these because such clinical scenarios are also asked in your exams. Is it clear to everyone, beta? Is it clear? Right. Let's talk, let's see this beautifully framed question in your FMGE 2020 exam. 18-year-old female girl while having her meal. So they've given a scenario in which there is a girl and it is related with eating. She cuts each piece into equal size to eat. She spends a lot of time while completing her meal. What is the diagnosis, beta? Again, this is what I am saying. Question, they will give you a question and they will trick you to, answer some other option. तो बेटा इसमें the first option उन्होंने दे दिया anorexia nervosa. It is not anorexia nervosa. We'll talk about what is anorexia nervosa. It is person is doing something symmetrically. Something symmetrically. Okay, the person has, the girl, she is cutting in equal sizes symmetrically. तो बेटा क्या है ये OCD. Is it clear to everyone? This is your exam question. Very, very important. Please remember these clinical scenarios. What is the treatment? Let's talk about few things about the treatment. Beta, what is the drug of choice? What is the drug of choice of OCD? SSRIs. There is one more first line drug. Drug of choice is this. Any other drug which is a first line drug, please remember we can also use clomipramine. We can use clomipramine. Yes, Anju, that was perfectionism. Yes, very good. OCD, Vikas, yes, you are correct. It is fluoxetine is one of the SSRI. So SSRI is a group. Yes, Devtaru. Dr. Vineet, very good. Clomipramine can also be used, but it is not, it is not a drug of choice because it has more side effects. Augmenting agent for OCD. Beta, augmenting agent matlab that we may add this augmenting agent to improve the effect of SSRIs or clomipramine. Please remember augmenting agents like antipsychotics. So antipsychotics को हम use कर सकते हैं OCD में, not as a first line drug, but to increase the effect of first line drugs. So we may add low doses of risperidone, aripiprazole with the first line drugs. What is the therapy of choice? देखो drug of choice है SSRIs, ठीक है? Okay, drug of choice है SSRI. What is the therapy? Therapies we use CBT and especially which we use ERP. What is ERP? Exposure and response prevention. This is the therapy CBT which we use. So if both the options are there in the question, CBT भी दिया है और ERP भी, choose ERP. Last question is treatment of choice. बेटा drug of choice था, थेरेपी ऑफ चॉइस था, अभी मैं पूछ रहा हूँ ट्रीटमेंट ऑफ चॉइस. डिड यू अंडरस्टूड दिस क्वेश्चन? Treatment of choice is combination, that means drugs and therapy. So SSRI plus you can also add therapy. Okay. हाँ, OCD you have to treat. Yes, functional impairment, it's a disorder, functional impairment will occur. Very good. Yes, correct Anurag, very good. Is it clear to everyone beta? These are, again you should know these points. देखो simple question था, देखो sometimes they give you certain images which I don't know whether it was totally not required, but ये अभी 2022 का question है, repetitive hand washing and they had given an image of hand washing. Of course we know what is hand washing, still चलो, but there in the same question they had given a very interesting image, so it's okay. The answer is very simple. So can you see so many questions they have asked on this topic? Very good, it is OCD. Look at this question. This image is very interesting. A patient underwent a surgery and a mass of hair was found in the stomach. If you can see the image, you know, the mass of hair has taken the shape of the stomach. Now, which specialist should be consulted after the surgery? It is your recently, it's a very good question, beta. What is this? This mass of hair is known as trichobezoar. Okay, and it may occur because of patient has eaten the hair, swallowed the hair, trichophagia, very good. Yes, Dr. Tusif, very good. And it is because of trichotillomania. Trichotillomania is hair pulling disorder. Patient is having recurrent urges to pull the hair. Usually the patient throw the hair, but here in this case the patient has swallowed the hair and they have got it collected in the stomach. So it's a complication. So surgeon has removed. Now the patient should be referred to a psychiatrist. Is it clear to everyone? This is a very good question. Okay. Yes, Dr. Vinith, you can, of course, you can refer. Right. Okay. Is it clear to everyone? Is it clear to everyone? Now better look at this again. Just I want you to remember few things from this image. Dekho beta. What ICD, let's try to look at this image. What DSM and ICD have done is, let's try to see what DSM and ICD they have done is, they have made a category of obsessive compulsive and related disorder in which they have clubbed certain conditions together. So what are the conditions included here? OCD, body dysmorphic disorder. Beta, body dysmorphic disorder matlab patient has preoccupations that there is something abnormal in my morphology. My nose is large, my nose is small, ears are large, ears are small. Hoarding disorder matlab patient is collecting things which is of no value. This is trichotillomania. So trichotillomania is also added, hair pulling disorder, and even excoriation. Excoriation ka matlab hai skin picking. Patient is now picking the skin. Trichotillomania mein he is pulling the hair, in excoriation is picking the skin. So these 5 disorders are now in the, yes, most common site of trichotillomania is scalp. Very good Anju, it is scalp, very good. Okay, so these 5 are there. ICD also has done similar thing. There are some changes, let me tell you. They have also included OCD, body dysmorphic disorder, hoarding disorder. What they have done is they have clubbed trichotillomania and excoriation disorder. देखो दोनों body part से related है, तो उन्होंने एक term दे दिया body focused repetitive behavior disorder. Body focused repetitive behavior. Trichotillomania भी add किया उसमें और excoriation भी. Another new entity which has been added, that there is a smell which is coming from my body. Patient को ऐसा लग रहा है कि मेरी body में से कोई bad smell आ रही है, but पेशेंट इज नॉट एबल टू स्मेल इट. बेटा अगर पेशेंट को वो स्मेल आ रही है तो वो फिर ऑल्फैक्टरी हेलुसिनेशन होगा, दैट विल बी ऑल्फैक्टरी हेलुसिनेशन. हियर ही इज जस्ट थिंकिंग. तो ये क्या है? ऑल्फैक्टरी रेफरेंस सिंड्रोम. दिस इज अ न्यू टर्म, यू नेवर नो, सच टर्म्स मे बी आस्क्ड. एंड ऑल्सो हाइपोकॉन्ड्रियासिस इज एडेड हियर. आई विल टेल यू क्या होता है हाइपोकॉन्ड्रियासिस. ओके, इज इट क्लियर टू एवरीवन? इज इट क्लियर टू एवरीवन? Thank you, Dr. Danwal. Okay, so we have INI-CET rank 8 with us. Thank you so much, Dr. Danwal. Thank you. Right, this is again important. Just few points, few extra points. Now, let's come to the next. Let's come to the next topic. 25-year-old male has a roadside accident. Now let us come to this topic: trauma and stressor related disorder. After which he is fearful of driving the vehicle and going to that place since 6 weeks. Beta, he is having flashbacks of that incident and difficulty to go to work. What is the answer? Beta, it is 2019 question. So there can be two, answer can be A or B. In this case it is B. Can anybody tell me why it is not A? ये A क्यों नहीं है? Can anybody tell me why it is not A? Can anybody tell me why it is not A? Very good, 6 weeks, very good. Dr. Divine, very good. Acute stress disorder will also have similar symptoms, similar stressor, but the duration will be less than 1 month. Symptoms will go away within 1 month. If the symptom last for 1 month, then we say it is PTSD. Very good, Dr. Tafsif, very good. Surila, Paras, very good. All of you are correct. So let us try to understand this entity of post-traumatic stress disorder. It's a stress disorder after a trauma. What kind of trauma? Major life-threatening, very serious trauma. Most of the time, in the question they may give this, that there is an accident, like in this case. But there can be other traumas like war or kidnap. Person was kidnapped. So there is a very extreme traumatic condition. Natural disaster like tsunami, earthquake. History of abuse, physical, sexual abuse, or some serious illness. ठीक है. So first there should be a major life threatening stressor. ठीक है, सबसे पहले एक stressor होगा. Symptoms will be for more than 1 month. Symptoms should be more than 1 month. Beta, what are the symptoms? Remember the symptoms with the mnemonic माही. महेंद्र सिंह धोनी का निकनेम क्या है बेटा? माही. जब माही बैटिंग करने आता है, he is a trauma for the opponent. So the mnemonic is Mahi. 4 symptoms, but 2 symptoms I want you to remember at least, because these are very important. Mood and cognition. Patient has a negative mood. Sir, after the accident the patient is very sad, very angry, or negative thoughts. Patient may have negative thoughts that I am a bad person, I am a bad driver, मेरी वजह से accident हो गया. तो ये mood and cognitive symptoms. Next is avoidance. Avoidance, he is now trying to avoid memories, feelings, objects, people related to that event. So now if you can see in the question, beta, he is fearful of driving, going to that place. So he is avoiding those places, situation, objects. He may be in a hyper arousal, condition, maybe very hyper aroused. Suddenly there is a noise, he is very hyper aroused. And last, again very important, intrusion symptoms or re-experiencing symptoms. Patient says, sir, entire event comes as a flashback to me. I am sitting and entire event comes in front of my eyes. एक flashback की तरह. Or I am having distressing dreams. I am getting distressing dreams. So again, especially avoidance symptom, beta, look for these symptoms. Avoidance, intrusion symptoms after a trauma more than 1 month. So if you see, he is having, these are avoidance symptoms, and these are intrusion symptoms. Okay, is it clear? And duration is more than 1 month. But how will you treat PTSD? Again, therapy is the treatment. Therapy of choice is CBT. Also you can use drugs like SSRI, but treatment of choice is CBT. Is it clear to everyone? Yes, Riya. Yes, so somebody is stuck in war, even soldiers, they may also experience this. Right, yes, CSK, Dr. Neet, yes. Okay, right. Is it clear? Very good. Yes, Krishan Kumar, CBT it is. Great. Let us come to this question, beta, again. Question of 2017. I have taken a slightly older question because ये एक important topic है. I would want you to remember these few terms. ठीक है? Worrying excessively that you have a serious illness and repeatedly visiting the doctor. एक patient worried है कि उसको serious illness है. Okay. So what is the answer, beta? Conversion disorder, somatoform disorder, hypochondriasis or depression? It is not depression. चलो इन तीनों में से बताओ. A, B और C. Conversion, somatoform and hypochondriasis. Beta, first of all, let's try to understand these 3 disorders are somatoform and related disorders. Usually what happens that these patients have physical symptoms. इनमें क्या होंगे बेटा? Physical complaints होंगी, physical symptoms होंगे, but उनका कोई physical cause या कोई there will be no physical cause. Patient says, sir, मुझे headache है, मुझे there is pain in abdomen, but there is no cause in the body. So there is no physical cause. So वो कैसे पता चलेगा आपको question में बेटा? They will tell you examination is normal and investigations is normal. So you may see that it is a, you know, it is a medicine question, but it may turn out to be a psychiatry question. So patient को complaints हैं but सब कुछ normal आ रहा है. So you can think of these three disorders. Let us discuss them one by one. So first is conversion disorder. Conversion disorder has a new name in DSM-5, functional neurological symptom disorder. बेटा neurological symptoms हैं patient को, but they are functional, they are not organic. Okay, there is no neurological cause. These may be sensory. For example, a patient says, sir, I cannot see anything, I have turned blind. So sensory हो सकते हैं, motor हो सकते हैं. मोटर मतलब पेशेंट में रिपोर्ट ऑफ पैरालिसिस, सर आई एम नॉट एबल टू मूव माई लिम्ब, बट आप इन्वेस्टिगेशन करो, एग्जामिनेशन करो, सब कुछ नॉर्मल है. पेशेंट में हैव स्यूडो सीजर्स, पेशेंट को सीजर्स आ रहे हैं बट दे आर नॉट ट्रू सीजर्स. मोटर सिम्टम्स कैन, सम पेशेंट कैन हैव बोथ. सो कन्वर्जन डिसऑर्डर, पेशेंट को सिम्टम्स है कन्वर्जन. एंड व्हाट इज ला बेला इंडिफरेंस बेटा? अगेन एन इंपॉर्टेंट टर्म, यू शुड नो व्हाट इज ला बेला इंडिफरेंस. It is careless attitude. It is careless attitude to a serious symptom. For example, if any of us will become blind, we will be very panicky. अगर हम 2-3 मिनट के लिए कुछ देख ना पाएं, will be very panicky. But this patient who is saying I cannot see, sitting very comfortably. So this is la bella indifference. The patient is indifferent to these serious symptoms seen in conversion disorder. This is conversion disorder. Patient को neurological symptoms हैं, right? Is it clear to everyone? This is conversion disorder. Now let's talk about somatoform disorders. Let's talk about somatoform disorders and hypochondriasis. Beta, how to differentiate these two? In somatoform disorder or somatization, patient is preoccupied of having physical or of having somatic, or you can write down bodily symptoms. Patient बस worried है, उसको बार बार symptoms है, sir I am having headache, sir I am having pain in my abdomen, I am having tingling sensation. So उसको बस bodily symptoms हैं. He has visited many physicians, many super specialists, everything is coming out to be normal. So this is somatoform. While hypochondriasis is patient is preoccupied of having a serious illness. Patient को ऐसा लगता है कि मुझे एक serious illness है. Sir, I am having headache. I think I am having brain tumor. So patient is having preoccupations or worries of having serious illness. Beta, conversion disorder, let's see again. Conversion disorder is neurological symptom. यहाँ पे नहीं है. Somatoform में patient को बस symptoms हैं. Here the patient is saying that I am having a serious illness. Symptoms हो भी सकते हैं, नहीं भी, but he is worried कि मुझे serious illness है. The answer is C. Is this clear to everyone? Devtaru, Dr. Tawseef, very good. It is C. Paras, Dr. Mukesh, Dr. Mohit, very good. It is C. Yes, it is C. Is it clear to everyone? This is again a small topic. I want you to understand these terms, because they may ask question. Now let's come to one of their favorite topics of substance use disorder. Let's talk about the substance disorders. Earliest symptom, again this is a June 2021 question beta. Earliest symptom or most common symptom of alcohol withdrawal. क्या आंसर है बेटा इसका? What is the answer of this question? Some said sir earliest पूछा था, some said sir most common पूछा था. Answer is the same, tremors. Very good, all of you are correct. Yes, Shalini, Preeti, Aditya, Riya, Krishnan, Anil, Devtaru, Anju, Kuldeep, very good. Dr. Mohit, it is tremors. Let's talk about beta alcohol withdrawal. Very very important. Suppose someone is taking alcohol continuously every day. Now the person suddenly stops alcohol. So after stopping alcohol, there will be withdrawal symptoms. Let's try to see what kind of withdrawal symptoms. In the first 6 to 8 hours after stopping, the patient may develop tremors. It is the most common or earliest symptom. Other symptoms like sweating, tachycardia, hypertension may also occur. By 8 to 12 hours, patient may have alcoholic hallucinosis. Patient may develop hallucination. Can anybody tell me which hallucinations will be more common here? Here auditory hallucinations will be more common than visual hallucination. By 12 to 24 hours, patient may also develop seizures. These seizures are generalized tonic-clonic seizures. Very good, Anju, Surila, very good. It is auditory, very good. Okay, these are also known as rum fits. ठीक है बेटा, rum fits भी बोलते हैं. Up to 72 hours by 3 days. Peak is usually during 48 to 72 hours. It is delirium tremens, which is an emergency. Which hallucinations will be more in delirium tremens beta? Visual more than auditory. So this is an emergency, patient can die, okay, in delirium tremens. Okay, can anybody differentiate alcoholic hallucinosis from delirium tremens? Very good. Okay, can anybody tell me how to differentiate alcoholic hallucinosis from delirium tremens? How will you differentiate? ऑडिटरी अल्कोहलिक हेलुसिनोसिस मतलब बेटा पेशेंट को हेलुसिनेशंस डेवलप हो गई हैं. ओके, हेलुसिनेशन नॉर्मली जो हमने डिस्कस किया. एंड यूजुअली अल्कोहलिक हेलुसिनोसिस में कौन सी हेलुसिनेशंस आर मोर कॉमन? ऑडिटरी आर मोर कॉमन. ठीक है, कैन एनीबडी टेल मी बेटा अल्कोहलिक हेलुसिनोसिस को और डिलीरियम ट्रेमेंस को कैसे डिफरेंशिएट करोगे? बेटा डिलीरियम है, आई टोल्ड यू डिलीरियम में क्या होता है. तो यहाँ पे पेशेंट की कंप्लेन क्या होगी? पेशेंट में अपीयर ऑल्टर्ड सेंसोरियम. पेशेंट की कॉन्शियसनेस क्या होगी? Patient की consciousness will be impaired. There will be impaired consciousness. Is it clear to everyone बेटा? तो आपको ऑप्शन में अगर उन्होंने ये बोल दिया in withdrawal state patient is confused, patient is disoriented, patient has altered sensorium, or they may say that there is clouding of consciousness, then you have to make a diagnosis of delirium tremens. Will you be able to identify delirium tremens in the question beta? Very good, Devtaru, Anju, Riya, dopamine agonist, Dr. Divine, very good. Okay, yes, Dr. Didi, it is correct. Is it clear to everyone beta? This is very important. They may just give one term confusion and the diagnosis will change to delirium tremens. Again a 2021 question beta, after 72 hours of cessation of alcohol, which symptom can be seen? All these can be seen, but more predominantly we have known that in 72 hours it is delirium tremens. Suppose beta they say in this, please remember this beta, this duration is not that always patient will have these symptoms in this duration. Suppose a patient just one day after stopping alcohol develops disorientation, then also you will make the diagnosis of delirium tremens. Please look at the symptoms, please focus on the symptoms. Okay, this is D. Very good, all of you mark correct, very good, it is D. Now let's talk about the treatment, how we treat patients with alcohol use disorder. One stage is detoxification, other is maintenance. बेटा डिटॉक्सिफिकेशन में हम क्या ट्रीट करेंगे? व्हाट विल वी ट्रीट इन डिटॉक्सिफिकेशन? विड्रॉल सिम्टम्स. वी विल ट्रीट विड्रॉल सिम्टम्स. ओके, व्हाट इज द ड्रग ऑफ चॉइस? व्हाट इज द ड्रग ऑफ चॉइस फॉर अल्कोहल विड्रॉल? ड्रग ऑफ चॉइस इज benzodiazepines. So we have various benzodiazepines like lorazepam, clodiazepam and diazepam. These commonly we use. Generally they ask you, suppose the liver is compromised, there is some liver disease. This question has also been asked. So which benzodiazepines you may prefer? Please remember important liver okay drugs. Two important benzodiazepines, one is lorazepam, other is oxazepam. Please remember these drugs, lorazepam, oxazepam, which can be given in liver disease. So they may tell you that LFTs are deranged or there is a liver disease. Very good. Is it clear? Along with benzodiazepine, would you want to add something else in the treatment beta? Along with benzodiazepines, would you want to add something else? Drug of choice is benzodiazepine, but would you want to add something else with benzodiazepines? You should also add thiamine. So अगर एक question में benzodiazepine and thiamine है तो that will be a better answer. Is it clear to everyone? So alcoholic hallucinosis में भी हम benzodiazepines देंगे बेटा. Hallucinations हैं तो does not mean we have to give antipsychotics. No, benzodiazepine will take care of that. अगर patient को alcohol withdrawal seizure है, then also we don't have to start any other anti-epileptic, but only benzodiazepines are enough. Please remember this. Very good. Yes, that was thiamine. Anurag, Anju, Aditya, Dr. Mukesh, Dr. Divine. Very good. We'll come to maintenance. Good. Now look at this question again, FMGE 2020. But many questions on alcohol have been asked. A man with a history of alcohol intake present in the hospital with tremors, disorientation to time, place and person, and auditory hallucination 2 days after stopping alcohol. What is the diagnosis? What is the diagnosis here beta? Can you appreciate this question beta? They have told you specifically disorientation has set in. What does that mean? The delirium, impairment of consciousness is occurring. So the answer will be very good. It is delirium tremens. Will you be able to identify this beta? Withdrawal state mein, if there is delirium, impairment of consciousness, delirium tremens. Now let's come to the maintenance. So we have two category of drugs. One is disulfiram. Disulfiram pe they have asked previously, एक old question, I have brought that question also with you. बेटा disulfiram क्या करती है? It inhibits which enzyme? Aldehyde dehydrogenase. Aldehyde dehydrogenase enzyme को it inhibits. देखो, alcohol in the body, ethanol is broken down into acetaldehyde by alcohol dehydrogenase, which is further broken down to acetic acid by enzyme aldehyde dehydrogenase, and then into CO2 and water. So what are we doing is, we give this drug to the patient every day. So what we have blocked? We have blocked this enzyme. So now suppose patient consumes alcohol. So as alcohol will be converted to acetaldehyde, but it will not be converted to acetic acid because enzyme is inhibited. So level of acetaldehyde will increase. Acetaldehyde is toxic and will lead to unpleasant symptoms. So patient after taking alcohol, he is taking disulfiram, he develops nausea, flushing, so all those unpleasant symptoms. So what he will do, he will get this message that whenever I am taking alcohol, I am getting these unpleasant symptoms. So he will be averse from taking alcohol. This is aversive agent. Disulfiram is a aversive agent. Then there is one more strategy which we can use, that is anti-craving agent. Very good. Anti-craving agent, two important FDA approved anti-craving agent you should know. One is acamprosate. Beta, what is the mechanism of action of acamprosate? Beta, acamprosate क्या करेगा बेटा? Memantine का mechanism of action was, what was the action of memantine? It was a NMDA. This is also a NMDA antagonist. It is also a NMDA antagonist. While naltrexone, what is naltrexone? It is a opioid mu antagonist. Okay, so these are anti-craving. They reduce the craving. So patient को जो craving हो रही है alcohol की वो कम होगी. Again, these are important questions which may come in the exam. Is it clear to everyone? Very good. All of you are correct. Yes. Anju, Surila, Dr. Bukesh, Aditya, very good. You are correct. Right. So let us see this question. Beta, simple question now. 2017, even older question. Disulfiram is used as, is it used as an anti-craving agent? No. Is it used in detoxification? No, it is not in detoxification, it is used in maintenance. It is a aversive agent. Very good. Not used in opioid substitution therapy, it is a very good aversive agent. Now next question, again an important topic related with alcohol. A patient taking regular alcohol consumption presents with neurological symptoms. Which of the following vitamin deficiency may be the cause? What is the cause here? Yes. So what is the cause here beta? This is alcohol induced neurocognitive disorder. कौन से deficient होगा बेटा? Thiamine. What is thiamine? Vitamin B1. Very good. It is thiamine. Correct. So thiamine deficiency alcohol के patient में क्यों नहीं है बेटा? Many reasons. First, it may be that poor nutrition है. Patient is not taking proper nutrition. Again, alcohol is decreasing the absorption of important nutrients from the GI tract. So deficiency of thiamine. So alcohol induced neurocognitive disorder. One neurocognitive disorder related with alcohol हमने पहले discuss किया बेटा. What was that? हमने discuss किया था ना, dementia में reversible cause of dementia is alcohol. तो वो भी एक neurocognitive disorder था. So Wernicke's encephalopathy and Korsakoff syndrome. Now both. Now let's talk about first Wernicke's beta. It has a acute onset. It has a acute onset. Suddenly symptoms develop beta. And the mnemonic you can remember is symptoms are GOA, global confusion. Sir, global confusion, ophthalmoplegia. So there is contraction of the ocular muscles. Sixth cranial nerve affected more than the third cranial nerve. Okay, sixth cranial nerve affected more then third cranial nerve. Okay, ophthalmoplegia. Patient comes with deviated eyes. I am not able to move my eyes. And ataxia. Patient is repeatedly falling. So he is falling. He is trying to walk and he is falling. Now please try to understand beta. यहाँ पे भी confusion है. withdrawal में भी, in delirium tremens में भी confusion थी sir, big confusion. Please understand, in withdrawal state along with confusion there will be other withdrawal symptoms. Here in Wernicke's encephalopathy along with global confusion other symptoms of Wernicke's will be present. वो withdrawal state में था. This can occur even in the phase in which patient is consuming alcohol. So this is how you can differentiate. Is it clear to everyone beta? Now, so they occur acutely and these are the symptoms. What is the cause? हमने discuss किया. Cause is vitamin B1 deficiency, thiamine deficiency. Thiamine deficiency. How will you treat? You will treat by giving thiamine. You will treat by giving thiamine. So this is Wernicke's. It is reversible. It is reversible. Symptoms will be reversed if you treat it with thiamine. Let's come to Korsakoff now. Korsakoff, again it occurs slowly. It is chronic sequelae, chronic. And I told you, we have discussed beta when we're talking organic disorders, I told you in amnestic disorders, Korsakoff. So symptoms are of amnesia. Amnesia, anterograde amnesia more than retrograde amnesia. Also confabulation may also occur. Confabulation का मतलब क्या है बेटा? Filling of the memory gaps with false stories. So wife asks the patient, where were you last night? The patient does not remember because there is amnesia. He starts creating false stories. This is confabulation. Cause is the same. It is because of vitamin B1 deficiency. Treatment also you will give thiamine. But some of the symptoms may remain. Symptoms may remain. So it is irreversible. Is it clear to everyone? It is irreversible. Very good, Anju. Yes, it is irreversible. Dr. Divine, yes, we will give, initially we can give in as parenterally and later on we may have to give orally. Is it clear to everyone? Thiamine. Look at this question again, 2021 question. Patient consumes alcohol and now presents with global confusion and ataxia. Beta, यहाँ पे confusion क्या? Ataxia and other associated symptoms. So diagnosis is Wernicke's encephalopathy. So which is the most appropriate? Many a times again I am giving you one important suggestion. Sometimes they give you some doses. So suppose you don't remember the doses, but please look at this. The answer you know, it is thiamine. The answer is very good. Thiamine. Very good. Riya, Preeti. Yes, Zishan, Devtaru, Paras, Medico VH. Yes, it is correct. It is better. It is not benzodiazepines. Better benzodiazepines you will give in withdrawal state. Patient has come to you with Wernicke's encephalopathy. Please remember ये Wernicke's encephalopathy है. He is consuming daily. They have not said कि he is come in withdrawal state. Is it clear? Right. It is C. Please make these questions. So this just one single slide. I just want you to remember about opioids. Opioids such as heroin. Most common abused opioid is heroin, diacetyl morphine. But one point about intoxication of opioid. This question has been asked repeatedly in various exams. You should know. So person has consumed, excessively overdose of opioid. So, they may give, a surgeon is doing a surgery, morphine was given and it may, was given in an overdose. So overdose ho gayi. So intoxication can occur, and in intoxication what will you find? You will find respiratory depression, pinpoint pupil or meiosis will be there, and coma. So a triad you can find. So they may give you after consuming opioid, respiratory depression, meiosis. So diagnosis kya beta? Intoxication ka. Drug of choice, you should know this. This is important. Please highlight this beta. Drug of choice kya hai? IV naloxone. It is a short acting opioid antagonist. This is important. How will you treat? Is it clear to everyone? Treat कैसे करोगे? This is your 2023 very interesting question. 2023 question. Common effect of cannabis or marijuana. देखो ये आपके एग्जाम का क्वेश्चन है बेटा. Marijuana. Depression, physical dependence, state of dreaminess with altered consciousness and anxiety. What is the right answer? This is the recently asked question. So such question they are asking. You should know about some of these intoxication. So please remember the answer. What is the answer in this case? It is not depression. It is not anxiety. Intake में patient को, cannabis intake में patient is euphoric. Patient is happy. So it is not depression, it is not anxiety. Physical dependence or again withdrawals, physical symptoms, they occur in withdrawal. So basically they are asking which of the symptom is of intake of cannabis. Answer is C. Answer is C. Let's try to understand cannabis intoxication. Various forms of cannabis, ganja, bhang, charas, hashish, marijuana, weed, these are cannabis. So intoxication में बेटा क्या होगा? Patient is in a euphoric state, very happy, elated. They may report of slowing of time. वक्त रुक गया है सर, धीरे धीरे चल रहा है. Slowing of time. Very important, redness of conjunctiva and increased appetite may be seen. This is important, you can mark this. Dry mouth, impaired motor coordination may be there, and increased dose में there may be delirium like state also. So these are the symptoms of cannabis intoxication. Yes, patient is happy. Okay, yes, marijuana is also a name. Yes, very good. Now what happens in withdrawal now? So it will be opposite. There will be irritability, anxiety and depressed mood. Decrease appetite. Physical symptoms, earlier we used, it was believed that cannabis does not cause physical withdrawals. It causes, although they are mild, such as tremors, sweating, fever, abdominal pain, chills. So physical dependence occur with cannabis. So now can you again mark, just see this question. Can you see this question again? Is it clear to everyone? This is a recently asked question. Don't make mistake in such questions now. Is it clear? Now this again 2018 question, very important, small topic, but again many questions have been asked. Tactile hallucination with jet black pigmentation is seen in alcohol, heroin, cocaine, cannabis. What is the answer beta? Tactile hallucinations, formications को और एक और नाम बोलते हैं ना बेटा, what we call them cocaine bugs. Cocaine bugs. Patient experience that there are bugs crawling under the skin. ये tactile hallucination है. Also known as formication. Magnum bugs. Very good. Magnum bugs. Very good. Okay. And patient also may have jet black pigmentation of the tongue. The answer is cocaine. Very good. The answer is C. Very good. Cocaine is a stimulant. It's a stimulant. So it increases the sympathetic activity. So it will cause tachycardia, hypertension, even cardiac arrhythmia. Seizures can also occur beta. Because of vasoconstriction, there may be nosebleeds. People snort it. So it vasal, bleeding may be there, and complications like nasal septal perforation, jet black pigmentation of the tongue. So they may, give you a presentation like a ENT question. They may give you an image of a, nasal septal perforation. Okay, so cocaine is a stimulant. Okay, so it will cause these symptoms, and we have discussed it. Cocaine bugs. When cocaine bugs, so physically you may get scratch marks also. So patient is scratching because of feel sensations of some insects crawling. Okay, so all these are important points. हाँ हो सकता है alcohol में भी Dr. Divine tactile can also occur in alcohol. Yes, they can occur. Generally, Dr. Tafsif, we don't treat intoxication of cannabis. Usually supportive care is there. You have to maintain the vitals, and supportive can gradually, if you see people consume it in Holi, Shivratri, and after some time they improve. So no specific treatment. Is it clear? No specific treatment. Okay. Now what are speed balls? But again this is an old question. Speed balls are if someone combines cocaine with opioids such as heroin. This is cocaine bug. So again please remember this. What are speed balls? Okay. What are speed balls? A female wants to get rid, again 2022 question, very interesting question. Tobacco, which of the following should be used? What is the answer of this? Yes, Anurag, it was speed balls is cocaine plus heroin. Very good. What is the answer of this question? Can you tell me what is the answer of this question? Very good. So we have two, varenicline and bupropion. So let me make it easy. इन दोनों में से एक बताओ. Tell me out of these two. Both of you are anti-craving agents for tobacco. So they have given both the options. Okay, so very good. Let us try to understand in tobacco, which is the psychoactive agent in tobacco which causes the addiction? It is nicotine. Okay, nicotine is the chemical substance which causes the addiction. One strategy is better nicotine replacement therapy. You tell the patient, why are you taking so many impure forms? We will give you pure. So there is nicotine gums, lozenges, patches we may apply on the skin, inhalers, and even nasal sprays. Okay, this is one type. Then other is anti-craving agents. Just like in alcohol, there are two anti-craving agents here. One is varenicline Please remember Werniclin is partial agonist of at alpha 4 beta 2. Beta 4 is coming first, alpha 4 beta 2 N nicotinic acetylcholine receptor. It's a partial agonist. And second is bupropion. We have discussed it. Bupropion is a NDRI. It is a antidepressant. Okay, so this question has been asked. It's a PYQ, antidepressant in smoking cessation. This is also an old PYQ of FMGE exam. So there the answer was bupropion. But here they have given both the options. So please remember, Werniclin is the most effective. Werniclin is the most effective. This is again very important. So the answer here is Werniclin. Please remember this. Werniclin, you can write down few points. Certain serious, black box warning with Werniclin is, so some of the serious effects can occur is it can increase suicidal thoughts. It can increase neuropsychiatric symptoms such as suicidal thoughts, and also it can increase cardiovascular events. Okay, cardiovascular events, especially in patients who have cardiovascular risk. Okay, so these are two important serious black box warning basically given with Werniclin. Is it clear to everyone? Is it clear to everyone? We'll talk about angel dust kya hota hai, we'll discuss. In fact, yehi question we are discussing. Now can you tell me one important old PYQ, but I've taken it here. Phencyclidine is also known as, very interesting, phencyclidine, it's an hallucinogen, such as even LSD is a hallucinogen, even ketamine is a hallucinogen, even MDMA is a hallucinogen, psilocybin from mushroom, that is a hallucinogen. What is another name of phencyclidine? Anybody? Yeah, very good. It is known as angel dust. This is your old question. So again, I am telling you, these questions may be repeated. MDMA is also known as ecstasy. Aham Brahma Asmi, I am God or one. Such feelings may occur. So this is another name for MDMA. Methylene dioxymethamphetamine. Is it clear to everyone? Again, such simple questions may also come. Now let's talk about child psychiatry. Again, substance is very important. Recently, many questions have come even from child psychiatry. Let's touch upon some important question. I'll tell you a new drug जो भी आपके INI-CET एग्जाम में आ गई है, जो हमने बिफोर द एग्जाम डिस्कस किया था, तो you should also know this drug. Okay. Okay, it's a hallucinogen. It comes in the category of hallucinogen. Amphetamine it comes under the stimulant. Cocaine and amphetamine, they come under stimulants. 6-year-old child with no interest in daily activities, not engaging in children of his age. Social communication is poor. Is it ADHD beta? ADHD में क्या symptoms होंगे? Inattention, attention deficit होगा and hyperactivity. Child has inattention and hyperactivity. यहाँ पे तो ऐसे कोई mention नहीं किया. What is this? What is this? It is autism. Very good. It is autism. Is it clear, beta? ADHD is attention deficit hyperactivity disorder. So autism spectrum disorder, this is a new term. So what DSM-5 and ICD-11 have done, so there are certain disorders which are similar. So what they have done, they have clubbed them together and given a name of autism spectrum disorder. Just like ADHD has 2 symptoms, autism spectrum has 2 symptoms. Deficit in social communication. The child is not communicating properly. The child may just sit alone, may not interact with others. And there may be some restricted repetitive patterns of behavior. कुछ behaviors हैं जो बार बार child repeat वही कर रहा है. So these are the 2 core features of autism spectrum disorder. Yes, ADHD, very good. It should have an onset before 12 years. ADHD, you are correct. For ADHD, the onset should be before 12 years. Let's come to autism. So disorders such as classical autism, Rett syndrome, Heller syndrome, Asperger syndrome, these are now clubbed under this category of autism spectrum disorder. So the answer was autism. Now, most of these are present more in males than females except one. What is the exception, beta? Rett syndrome. Rett syndrome is seen more with females than males. This is again a very important point. Okay. Let's talk about Rett syndrome. I told you it is females more than males. The child, what happens in Rett syndrome? In the first 5 months after birth, the child has normal development. You don't see any abnormality. But the problem starts from 6 months to 2 years. There will be stereotypic movements. I told you some like hand wringing movement. Again, this is given in the questions many a times. These are midline, hand movements like these, non-purposeful movements. Microcephaly, there is decrease in the head circumference. So if I ask you that in Rett syndrome microcephaly is seen at birth, it is not true. Microcephaly is seen after 5 months. And if they give you macrocephaly seen after 5 months, no, it is micro. So please read the words carefully. They may just play with the words. Is it clear to everyone? Loss of speech, muscle coordination may also be affected. Patient may have ataxia. Seizures may also be commonly seen with these patients. This is Rett syndrome. But this is a new drug which is recently approved. This is again a FQ. This has been asked in the last INI-CET exam. Can be asked in your exam also, because it's a new drug which is approved for Rett syndrome. Trofinetide. Okay. Debut is a brand name. Debut kitna you can remember. Just remember trofinetide. It is a tide. It is a tripeptide of glycine, proline and glutamic acid. It is an analog of amino terminal of tripeptide of IGF-1. IGF क्या होता है बेटा? Insulin-like growth factor 1. It has anti-inflammatory properties. It stimulates synaptic maturation. Do remember the name trofinetide. It is used for children more than 2 years. It is at present approved for children more than 2 years. Is it clear to everyone what is trofinetide? This is a new. So today 2 new drugs I have told you. What was the previous new drug which I have told you? Anybody? What was the previous new drug which I have told you? Does anybody remember? Starts with B. I told you one drug, brexpiprazole, right? This is another new drug. A student having difficulty in his studies. IQ is 55. This is 2020 question. What is the diagnosis? What is the diagnosis here? Mild, moderate, severe or borderline? So basically we are dealing with mental retardation. Low IQ is there, mental, very good. Paras, it was brexpiprazole, very good. Is it mild or moderate? It is mild mental retardation. Let's try to see this. Mental retardation in DSM-5 has given a new term. So we don't use this term mental retardation now. Intellectual disability. Intellectual disability. ICD-11 also uses a similar term, disorder of intellectual development. Okay. So we say IQ is less than 70. So mild is when it is 50 to 69. So 55 would come in this range na. This was mild. Moderate is 35 to 49. Severe is 20 to 34. And profound is less than 20. But one more question, an FQ beta, what is the most important feature which you will see to assess the severity of intellectual disability or mental retardation? सबसे ज़्यादा क्या important है severity के लिए? Is intelligence or IQ more important? No. So we say for assessing, so we don't have to always do an IQ test to know the severity. We say that to see the severity, adaptive functioning of the child, so his day-to-day behavior, practical skills, social skills, those things, you take a history from the parents. So from that we can assess the severity. So yes, we also do IQ, but most important is adaptive functioning to see the severity. This is again an important point. Is it clear? This is again an important point. Next question. A child is having difficulty in writing. This is 2020 question. So एक exam में they had asked 2 questions on child psychiatry in 2020, due to which he is having poor marks in exams. He is otherwise good in mathematics and has normal social behavior. So child is normal in most of the things, but he is not able to write. There is poor writing skills. So what is the answer here? The answer is C. It is specific learning disability. Very good. It is SLD. As the name suggests, beta, specific learning disability. It is a neurodevelopmental disorder. Even ADHD, even autism spectrum disorder, these are also neurodevelopmental disorder. These are not behavioral disorders. Please remember this. Here the child has poor academic skills. So the child may be poor in reading, which is known as dyslexia. Okay, very good. You saw a case, Dr. Divine, good. So it's good that you start identifying these things. Again, important, very good. All of you have marked it correct, very good. It may be problems in writing. The child has poor writing skills, like in our case, or may have poor mathematics skills, or may be mixed. It may be a combination. This is SLD. Is it clear? SLD. Very good. This now let's talk about this topic, because this is one topic. Do not go. You, of course, you can go to, give the exam, but try not to go to the exam without studying lithium. Okay, of course, chale jana, but try to read lithium, because lithium is a topic. 1 or 2 questions they are asking. This is your 2023, again the last exam. A 25-year-old female having bipolar disorder is on lithium. Lithium is, we have discussed, it's a mood stabilizer. Which of the following statement you have to say is incorrect? Can anybody tell me? Lithium decreases thyroid function. Yes, it decreases. It causes hypothyroidism. Also hyper, but hypo more. Thiazides increase lithium toxicities. Yes. So whenever we give thiazide to a patient on lithium, we have to decrease the dose of lithium. It is avoided in pregnancy. Yes, it causes a teratogenic effect, which is known as Epstein anomaly. The answer is very good. All of you are correct. It is the incorrect statement. Hemodialysis is useful in severe lithium toxicity. Few points about lithium beta. Person who has done a lot of studies establishing the use of lithium in mood disorder is John F.J. Cade or John Cade. Remember the name. Therapeutic range of lithium is very small, very narrow, 0.5 to 1.5 milliequivalent. Less than this, not effective. More than this, toxicity. In acute mania, we have to give the blood level should be higher. 1 to 1.5 is the dose, is the therapeutic range, is the range for acute mania. Maintenance, slightly low, you can give 0.6 to 1.2. Toxicity will occur if it is more than 1.5 milliequivalent per liter. Right. Let's talk about some side effects. Patient is on lithium. Neurological, patient may have tremors. So patient may have tremors. Okay. And usually, what is the treatment? Drug of choice for lithium induced tremors? We can give drugs such as propranolol. Okay. Propranolol. Endocrinal, yes. Hypothyroidism can occur. Hyper can also occur, but more hypo. In renal, polyuria can occur because lithium inhibits the effect of antidiuretic hormone. Usually in the treatment of lithium induced diabetes insipidus, fluid replacement is to be done, and we can use thiazides or potassium sparing diuretics. But you should know that thiazide, it decreases lithium clearance. So whenever you give thiazide, there is chances that lithium toxicity can occur, because it decreases lithium clearance. So it can increase lithium levels in the blood. Okay, so always reduce lithium if you have to give patient thiazide. So this is again important. Coming to toxicity, toxicity is when it is more than 1.5. So again, I have given you symptoms. So it can be mild to moderate. In mild to moderate, symptoms such as GI symptoms like vomiting, abdominal pain, ataxia, nystagmus, muscle weakness, CNS symptoms can occur. More severe 2 to 2.5, it is moderate to severe. Anorexia, nausea, vomiting. CNS symptoms again will be more severe, hyperactive, deep tendon reflexes, convulsions, stupor, coma may occur. And in severe is more than 2.5, generalized convulsions, oliguria, renal failure, and even death may occur. So lithium toxicity is very, very important. You should know the symptoms. Okay, you should know the symptoms. And lithium toxicity can occur in situations such as dehydration. So patient is on lithium and he is dehydrated. Let us say he is on fast. So lithium toxicity can occur. So suppose patient on lithium is fasting and he has developed vomiting, abdominal pain, nystagmus. What will you do? Next step will be to check lithium levels. Okay, to check lithium levels. Okay, yes, correct. So again, coming to the treatment of toxicity, stop lithium, correct the hydration. If there is unabsorbed lithium from the GI tract, remove that using polyethylene glycol, sodium polystyrene sulfonate. Activated charcoal has no role. Okay, has no role. In severe cases, we have to remove it from the blood, hemodialysis, and sometimes multiple times we have to do hemodialysis. So hemodialysis is useful. So if we go back to this question, is it clear now, beta? Hemodialysis is useful. You have to tell the incorrect. This is your 2023 question, right? Now June 2022, again I am saying these questions are occurring again and again. Pregnant female bipolar disorder, okay, pregnant female, yes, we do it along with those drugs, yes, we do that, yes Surila, okay, but activated charcoal usually has no role, okay. Which of the drugs should be avoided? Please remember, I told you in pregnancy, antipsychotics are preferred over lithium. So antipsychotics, these are, we can give even lamotrigine, it is also mood stabilizer, although it does not have a role in mania, but in bipolar depression we have, but it is also less teratogenic, it is also not teratogenic. So which we have to avoid? We have to avoid lithium. Please see this again, lithium is teratogenic, it can cause Epstein anomaly, it is a cardiovascular defect, okay. So it is the answer, okay, lithium is the answer, okay. Suppose valproate was there, then of course you have to, because valproate can cause neural tube defect, okay. So we can give lithium, but you have to monitor the patient and also do repeated monitoring, and also it is incidence is, prevalence is less, valproate it is more, and it is, this neural tube defect has a very poor prognosis, it is a CNS defect. Now this is 2018, it's an old question again. Please see which of the following statement is true. Lithium is protein bound. No. Lithium, please remember, lithium is a element. What is lithium, beta? In our chemistry school days, you must have, periodic table mein lithium padhe, it's an element. It is basically absorbed almost completely from the GI tract, almost completely, and it is absorbed fast, okay, and it is not bound to protein, not protein bound, okay, and it is eliminated by kidney, and it is unmetabolized because it is an element. How would you metabolize an element? Okay, it is eliminated by kidney. So these are some important points you should know. Now let's try to solve this question. You have to tell the true statement. Protein bound, no. Delayed absorption, no. It has a rapid absorption. Used safely in renal destruction, no. Again, because again in renal disease it is eliminated by kidney, so you have to decrease the dose, and if it is severe you may have to avoid. Narrow therapeutic index, this statement is correct. So if you see, yes, very good, all of you are correct, great, it is D. Let's talk about this again. 2021, nearly in every exam they are asking question. Lithium, she visits. Antenatal checkup, which condition fetal is at highest risk? So what is the answer? The answer is, beta, Epstein anomaly. Lithium, we are talking about lithium. Neural tube defect is with valproate. Valproate, even carbamazepine can also do neural tube defect. Very good. Now these are some questions which now I am discussing. They have been asked once, but let us just discuss them so that if they are asked, you should know these questions. A boy did a murder, so a boy did a crime. A boy, they are asking, please see, it is a boy, so it seems like a child, and when the police arrested him, he was worried about his jacket he left behind the crime scene and not about his arrest by the police. So what is this phenomena? Is it antisocial personality disorder, conduct disorder, ODD, oppositional defiant disorder, or adjustment disorder? But adjustment disorder nahi hai. Adjustment disorder generally has mild symptoms after a mild to moderate stressor. ठीक है, किसी का mild to moderate stressor हुआ तो mild symptoms आते हैं. It is also not antisocial personality disorder, beta, because personality disorder, I told you, they occur by around 17-18 years. They occur in adulthood, late adolescent and early adulthood. So they are disorders of adulthood, okay, personality disorders. So out of conduct and ODD, what is the answer, beta? Yes, very good. So these are disruptive disorders of childhood. Two disorders important we are discussing. One is oppositional defiant disorder or ODD, and the other is conduct disorder. These are disruptive disorders, okay. There are disruptive behaviors in the child. Now ODD, as the name suggests, the child is opposing or is defiant to authority figures. So there is a pattern of negativistic, pattern, of behavior. He is very disobedient, very hostile to the authority figures. Authority figures, matlab his parents, his principal, school teachers. To them, he speaks very badly, very rudely. He is always disobedient. But these children do not resort to any physical aggression or destructive behavior. They will not harm someone. They will not resort to physical aggression. Only behavioral symptoms will be there. They will not resort to such destructive behaviors. While conduct is more severe, pattern of behavior is characterized by aggression, violation of rights of others. They will beat anyone, they will bully their juniors, they will harm property, they will hit animals. So this is conduct disorder, and they would not have no guilt, no remorse for any act which they have done. So if you see here, the child has committed a murder. Okay, so there is a violent behavior. So the answer is B. It is not antisocial personality disorder because it occurs in adults. Is it clear to everyone? This is correct. Very good. Now this again, some questions. Excessive sexual desire in males is known as, satyriasis. In females it is known as nymphomania. Okay, in females it is known as nymphomania. Again, these are old questions, they are asking again and again. You should know these terms. Okay, this is nymphomania. Now also remember, in premature ejaculation, so some therapies name you should remember. I will tell you some important names of these therapies. In premature ejaculation, the therapies which we use is, these are your old question, squeeze technique and stop-start technique. These are PYQs, beta. The therapy used in premature ejaculation, the ejaculation is occurring early. Therapy used in ED, erectile dysfunction, is known as sensate focus technique or exercise. Sensate focus exercise. Please remember these names, very, very important. Overall, generally we say for sexual disorders we use dual therapy. Dual therapy means we don't treat the patient, we treat the couple. And specific psychotherapies for PME, these both have been asked in old questions, very, very important. Squeeze technique and stop-start technique. Which of the following is an indication of admission in anorexia nervosa? Again, it's an old question. Anorexia nervosa, this topic, they've been asking in different exams. Anorexia nervosa is a eating disorder in which there is restriction of food intake leading to decrease in the weight. So patient eats less, patient feels that, patient fear gaining weight, that I will gain weight, and there is a disturbed body image. Okay. All these eating disorders are more common in females than males. So patient in anorexia nervosa restrict herself of eating food, there is decrease of weight and BMI, there is a fear of gaining weight, oh my god, I'll gain weight, and disturbed body image. Patient is thin but feels that I am obese. So amenorrhea, please remember, these are the three criterias of anorexia nervosa. Earlier there was a fourth criteria, which was amenorrhea, which has now been removed from the core criteria. So amenorrhea is not the answer. They are asking indication for admission. These patients are very difficult to treat. Depression can occur, but depression is not an indication for admission. Yes, had they mentioned suicide, then that could have been an indication for admission. Binge eating, yes, even anorexia nervosa patients are of two subtypes. One is restrictive subtype in which patient eats very less, and other is binge eating and purging. So binge eating, purging is also seen with anorexia nervosa, but again that is not an indication. Yes, so as you can see, weight for height less than 75% of the normal, yes, it is an indication. BMI of these patients is very, very less, maybe there. Now anorexia nervosa, so again hospitalization may be required to restore patient's nutritional status, okay, because patient is not eating. To manage complications such as dehydration, electrolyte imbalance can occur, okay, and also patient who have 20% below the normal weight for height, that is also an indication for admission. Okay, so these are some serious problems for which we have to admit the patient. Treatment is difficult. Anorexia nervosa has high mortality. The mortality with anorexia nervosa is very high. Okay, it's high. Yes, so difference between binge eating and purging. Okay beta, the question you have asked is, now you only tell the difference between, I have talked about anorexia nervosa, the difference between bulimia nervosa and anorexia nervosa is beta, in anorexia nervosa patient have these symptoms first. There is a decreased restriction of food intake, decreased weight, fear of gain weight, disturbed body image, and now we are saying along with this there are episodes of binge eating and purging. While in bulimia nervosa there is only episodes of binge eating, patient eats a lot and then uses compensatory mechanisms, purging, self-induced vomiting, laxatives, all these things. Yeah, very good. So can you differentiate? In bulimia nervosa there will be only episodes of binge eating and purging, while in anorexia nervosa these symptoms, especially restricted food, decreased weight is there. So weight is a very important factor. In bulimia nervosa the BMI may be normal or increased, while in anorexia nervosa it is decreased. Is it clear? This is again important. Is it clear to everyone? Right. Now next question, again such questions may occur beta once, or once in a while such questions come where we may be confused. So the question which was asked was most common emotion. Again it was taken from some study. So which is the most common emotion? Again just to know, okay, just to know, it is usually say joy more than love. So joy is the most common, love is given in the option, so it is love. Okay, please remember this. Very good, very good, it is love. Next, again forensic questions, especially this question has been asked multiple times. McNaughton's rule, which of the following is related with McNaughton's? Anybody? Can anybody tell me what is the answer? McNaughton's rule, it is basically criminal responsibility. Okay, they are trying to see criminal responsibility. The answer is IPC 84. So basically section 84 of the IPC, it embodies McNaughton rules. It says that nothing is an offence which is done by a person who at the time of doing it by reason of unsoundness of mind, that means there is some problems of the mind, is incapable of knowing the nature of the act or that he is doing is wrong or contrary to the law. So अगर किसी को ऐसी unsoundness of mind की, that is some psychiatric problem है जिसकी वजह से he is not able to know the nature of the act or what he is doing is wrong or against the law, if he does something wrong, then that will not be considered as a offence. So this is criminal responsibility. Is it clear to everyone beta? Is it clear to everyone? This is criminal responsibility. This was all, these are, so what I've tried to do, I've tried to compile all the possible PYQs so that you have them together. Again I'll say, have faith in yourself beta. You have 65 days. It is the attitude with which you think. You can say, sir, only 65 days, or you can say, sir, 65 days, more than 2 months. Even if you have not started well, or even if you have halfway, let me tell you, you can still make it. You can clear the exam. Beta, आपको rank नहीं लानी, you have to cross that 150 mark. So make each day count and हो जाएगा. You will be able to clear it. It will be done. Okay, it will be done. Right, so thank you very much beta. As I always say, keep smiling, keep moving forward. You will clear the exam. May God bless you all. Thank you everyone. Thank you so much. Thank you. Thank you everyone.